Darius, if you
Yes,
want to start, because it's 9 o'clock.
it's 9 o'clock. So
Okay.
my warm welcome to everyone in front of screens. Unfortunately, we cannot meet together, but I hope that we will meet in near future. So once again, very warm welcome to all of you. I think that we are getting more and more people around, just more than 80 people right now. So I am really very happy that our group that has the name Live, it means that we are really living, connecting so many people around the world. I am very happy. So thank you very much for joining us. Thank you, Mario, for preparing such an interesting program, because the program looks really very busy. We have a lot of lectures, and also we have live surgery from different centers in Italy, also from Poland. So we'll show you today a lot of very interesting cases, and sorry if we will change our program, because it's a live surgery, so everything can change. So right now we will start with our first point at our program, live systematic review from Valerio Gentilo. Valerio, are you
Good
online?
morning.
You are.
Good morning, everybody.
Good morning. Good morning.
I'm going to share my screen.
That's okay. We can see.
Okay, so dear colleagues,
Works.
on behalf of our junior speakers, I thank you all for this opportunity. Today, I've got the privilege to open our live meeting, introducing a new edition of the Live Systematic Review. I really like to go in briefly through last topics, namely anorectal malformation, urogenital sinus surgery, gastroesophageal reflux, esophageal atresia, neurologically impaired children's surgery, urethral reimplantation, inflammatory bowel disease, bariatric surgery, inguinal hernia surgery, and pediatric gynecology surgery. Today, we will talk about an extremely wide topic such as pediatric thoracic surgery. Aim of the session is, as always, to get recent articles within the last year and make them user-friendly. And so they did. They looked back to the beginning of last year until yesterday evening, and after applying pediatric filters, they got 1,422 relevant articles. And here they are. This is a summary of what they found. And again, as always, they liberally picked up one article each. So who are them? We all know them, actually. It's Marco Dimitri from Bologna, Xara Dimitri from Thessaloniki, and Carlo Perlini from Pavia. So this is the up-to-date map. It's getting busier and busier, but as usually, I kindly ask our junior surgeons from all around Europe to present themselves as potential new speakers, and our seniors to push them as hard as they can for the next live systematic review that will be held on the 16th of April on heminephrectomy surgery. So my apologies for taking your time, and my thanks to our young surgeon that I've got the privilege to coordinate and to whom I'm now giving the floor. So please, Marco, you can share your screen and start with the live systematic review. Thank you, everybody.
A moment. Wait a moment, please.
We are waiting.
Don't be so scared, Marco. Everything's gonna be fine.
Okay.
Okay. He disappeared.
I mean, if Marco is in trouble, we can move to Xara or Carlo. Xara, are you ready?
Buongiorno. Good morning, Professor. This is Jara.
Can you hear me?
Oh,
Now
yes.
we can hear you, Marco.
Okay, now I'm ready.
Okay, we move to Xara, but if you want, you can carry on.
As you want.
Okay, Xara, carry on, please.
Yes. Thank you, Mario. Can you see my screen?
Yes, we can.
Thank you. Can I try the full screen if you see something? Okay.
No,
Well, I say we can, but actually we can't. Okay, now we.
that's
You see? Okay. I'll try with not the full screen. Today I will present the case report, a paper that was published almost half a month before. It's a pneumothorax after VATS for pleural emphysema in pediatric patients. As we all know, bacterial pneumonia is the most common cause of neuroparapneumonic pleural effusions, and this can cause pleural emphysema. This is what we face most of the times during spring and winter, at least in my country. The treatment consists of antibiotic therapy with a combination of chest tube drainage, fibrinolytics, and finally, if all those meters does not work, we do VATS. The complications can be pneumothorax and bronchopleural fistula. The aim of this study was to investigate the incidence and the duration of pneumothorax during the perioperative period and the follow-up. And the researchers wanted to elucidate the progression of pneumothorax following the VATS. And they wanted to create an evidence-based standardized follow-up protocol for those children. This is a retrospective study which studied the patients who underwent VATS for pleural emphysema from January 2013 to May 2023 in Hamburg, in two hospitals in Hamburg. As we can see, if the fever persists in pneumonia for over 2 days and the patient has suspected parapneumonic effusion, we perform a chest radiograph and ultrasound, and then we start the intervention antibiotic therapy. And if we need an extension of therapy, we may use a chest drainage or with a combination or not with fibrinolytics. And if this do not work, we perform VATS. Regarding VATS, we have to consider surgery when the initial treatment does not work. The early VATS, according to the literature, improves the chances of full lung expansion. But unfortunately, in children, the efficacy of VATS in pleural emphysema is not supported by a lot of evidence because most of studies are absent. They reviewed 166 patients with pleural emphysema. From them, only 47 patients underwent the VATS. 43% of them were found to have pneumothorax, and 55% of those, the pneumothorax were unresolved at the discharge. At the follow-up, 24 of those had a pneumothorax ex vacuum. According to this study, no surgical interventions were needed regarding the pneumothorax that stayed after the discharge. We have to focus on this table where the chest tube prior to VATS and no chest tube prior to VATS did not affect the final length of stay for the hospitalization. And this happened also regarding the use of fibrinolytics. About the conclusions, the majority of pneumothorax after VATS in pediatric patients can be managed conservatively. This is a graph that shows that as the time passes after the discharge, the pneumothorax is not detectable radiologically. And the duration from discharge to radiological resolution in days was estimated after 3 months. The follow-up care is not standardized. They tried to standardize the follow-up care in order to eliminate the X-ray examination and promote the sonographic follow-up examinations. And according to the British Thoracic Society, the clinical and the radiological follow-up for at least 4 to 6 weeks after discharge is proposed for children. If the pneumothorax persists after this follow-up, the next step is thoracoscopy for resection of possible visceral pleura and a treatment of bronchopleural fistula. The discharge from finally, I put here the table that says the follow-up algorithm that those researchers established after the patient discharged from hospital. Once we discharge the patient from the hospitalization, there is a regular clinical and sonographic monitoring every 2 weeks. And we continue the oral antibiotic therapy for at least 2 weeks following the cessation of fever or until infection parameters normalize. A chest radiograph is performed once within the next 3 to 6 months. The median follow-up period in this study was 39 days, and the median number of chest radiographs during a follow-up was only 1. They focused a lot in this proposal to avoid X-ray overuse in children after complicated pneumonias. And this is my presentation.
Thank you, Xara, for your presentation, and the paper is open for discussions. Any question from the audience?
I have a comment on this paper.
Please go ahead.
As I was studying this research, I saw that they did not give any percentage of the pneumothorax that they do not interfere with surgical treatment. They used the term pneumothorax after VATS, but they did not describe exactly the percentage of the pneumothorax that they accept.
Okay. Do you have? Yes. Do you have any protocol similar in your hospital?
No. We do not follow any protocol, and most of the times the pneumonias and necrotic pneumonias, after we do not perform VATS. It's the last solution. We do not use it in an everyday practice. But after that, only pediatricians have the follow-up of the complicated pneumonias that demanded thoracocentesis or below treatment.
Okay. Question and comments from the audience?
It's really difficult to select patients if you have a pneumothorax after VATS, which one is for drainage, which one is just for observation, because, it depends on whether this is, how large it is, whether this is just only very thin or maybe it's completely collapsed lung. So it's really very difficult.
The only comment, Professor Patkowski, is that all patients who were discharged had no symptoms.
Mm-hmm. Okay.
They had the image established pneumothorax, but they did not have any symptoms regarding the oxygen supplementations or something like that. And this is, I think, that it is a restriction in this study.
If you have a patient for the drainage of the chest, do you perform just only a drainage in a local anesthesia or in a general anesthesia? How you prefer to do it?
It depends on the age and the kind of the character of the child. We prefer to use local anesthesia, but in the operating room in order to have monitoring. And most of the times we perform a single hole, which is small enough in order to use our finger and remove the peeling of the lung if this is needed.
At our department, if we have any patients with rear empyema, and if the patient is considered for any drainage, it's our custom to take the patient to operating room and in general anesthesia just to put a scope to see what's going inside. And if it is just only a fluid, we just put a drain. If there is any fibrin, we just try to remove it, So I think that it's not too much invasive just to put the scope in every patient that has a pleural effusion. Yeah.
Okay. If there are no questions or comments, I think we should move to the second article presented by Marco. Are you ready, Marco?
Please switch your microphone, Marco. That's good.
Wait a moment. Can you see my screen?
Yes, carry on.
Okay, thank you.
Marco,
one moment. Darius, there is a question for you from the chat.
Sorry, I just check at the chat.
Farman Ali. I want to ask to Professor Paskowski about personal practice, about removal of ICD after pneumothorax. You see?
Yes, I can see. What does it mean, ICD? Sorry.
Intercostal drain.
Yeah. So we remove it just when there is no drainage, and we usually clamp the drain. But right now we have a new suction device that are electronic devices that check what the leakage. So we can estimate the real leakage through the drain, and if there is no leakage, we can remove just the drain. But usually when there is any leakage, when we can see that there is still the air coming through the drain, we keep it until it stops. Or if it is a small amount, because sometimes, there's a leakage around the drain, even possible, So we just clamp and check whether there's any pneumothorax that patient can stand with this pneumothorax. So there is not a simple rule. The simple was just no leakage, we take the drain out. If for 24 hours there is no leakage, yeah? That's okay?
Professor
Marco?
Lima, I got Professor Lima, I got a message from Michele Torre. He says he's ready to present his case if you want.
I think it's better that you go with Marco and after, okay?
Okay, Marco, you can carry on.
Okay, thank you for the presentation, Dr. Gentilino. Today, I would like to present this paper that is a systematic review published on Journal of Pediatric Surgery entitled The Evaluation and Management of Primary Spontaneous Pneumothorax in Adolescent and Young Adults, a systematic review from the American Pediatric Surgery Association Outcomes and Evidence-Based Practice Committee. So primary spontaneous pneumothorax is a common condition that managed by pediatric surgeons that occurs in the absence of pre-existing pulmonary pathology or trauma, and it is more common in tall and tiny males. So what today miss is the consensus on management of these patients. So the authors focused on 6 unanswered questions about PSP, and especially about the optimal initial management and the cross-sectional imaging, the optimal timing to perform surgery, the most effective surgery, and what to do with the asymptomatic contralateral side, and in case of recurrence. So the wishing aim of this paper is to find answer, to find a consensus to these unanswered questions. And so the authors conducted, to reach this goal, the authors conducted a systematic review about spontaneous pneumothorax, including patients with an age under the 18 years old. They selected the 2497 papers that were reviewed by 3 of the authors that finally selected the 79 paper that they included in this systematic review. So about the results, about the first question, about the optimal initial management, actually potential intervention in case of PSP are observation, aspiration, chest tube placement, and primary VATS. So the authors concluded that about the optimal initial management is suggested only observation if the severity of symptoms and patient stability allow it. Contrary, they affirmed that about intervention, the role of only aspiration is equivalent to the chest tube placement with the grade B of evidence, while a more aggressive primary VATS may reduce the total hospital days and readmission, concluding as it should be considered in selected patients. About the second question and the imaging, literature reach consensus about the use of X-ray and CT scan for the diagnostic workup of this patient. But the authors found that the CT scan positive test does not predict recurrence, and the negative test does not provide reassurance. So they concluded that the CT scan appears to be no advantage with a grade B of evidence. About the optimal timing, the authors showed that continuous air leak may be considered predictive of failure and can guide decision-making to early surgery. And particularly, they defined the failure as the failed aspiration after 6 hours, or a failure of the chest tube placement after 48 hours. About surgery, the authors included the 38 studies about these questions, and they are the primary option seems to be the stapled blebectomy associated with the pleural procedure, while apical wedge resection is indicated only in cases where the lesion is not microscopically identified. About the contralateral side, so about the role of prophylactic VATS, the author showed the grade C of evidence about the VATS, so it's not recommended in the absence of symptoms. And finally, about the recurrences, the authors divided the patients into groups. Patients with small pneumothorax and minimally symptomatic, and patients with large pneumothorax and more symptomatic. For the first group, the author suggests as only observation is a reasonable option. While if you have recurrences with a large pneumothorax and symptomatic patients, you need to perform a redo of the VATS associated with a more aggressive pleural treatment. So, concluding, contrary to other meeting, I want to open the discussion, ask to the discussant if you think that now we can reach a consensus about the management of spontaneous pneumothorax in children. Thank you.
Thank you, Marco, for choosing such an important paper and for making it really user-friendly. Now the paper is open for discussion.
How many cases do you have in everyday practice in your departments? Is it very common? At my department, I guess we have 3 or 4 cases a year, so it's not too much.
No, also in our department, we have the same cases. Last year, we reached 8 cases, but it's similar, the sample.
And what's your approach, Marco, in your center?
We usually base our decision on the clinical condition. So usually a chest tube placement is the first line treatment, followed by VATS for bullectomy or apical resection. And in case the CT scan revealed the bulla in the other side, we usually perform the bullectomy also in the asymptomatic side. But standing on the results of this paper, maybe we should think to consider a primary VATS as first approach to reduce the hospital stay. I don't know.
Are you using any oxygen therapy and just to have a faster resolving?
No. We use oxygen therapy also if the clinical condition of the patients require it. We based on saturation.
Some people say that if you are giving an oxygen therapy for 24 or 48 hours, the pneumothorax would resolve much faster than usually. What's your opinion?
I use oxygen therapy after drain intercostal insertion because it reduces the work of the lung and facilitates the healing of the bulla.
Okay.
Okay, we've got a question from
Giovanna
Yes.
writes to me.
Thank you very much and congratulations for this very nice study and work that you did, Marco. But I agree with the conclusion of this paper. But I have a question for you. I suppose you
Giovanna, we don't hear.
about different type of
Sorry, Professor, can you repeat the question because the connection is unstable?
We don't hear.
Did you find any paper on the result of different types of treatment of the pleura? I mean, brushing of the pleura versus talc, and the long-term results of talc treatment, which is largely used in adults, but children are a little different.
No, we focused about the recent paper of the last year, and I don't find any paper about the pleural treatment, the best pleural treatment. Usually, what do you use?
Oh, it depends. We don't use talc as first choice. It's just the last choice in case of several recurrence after VATS. But I always hesitate thinking to long time sequela of this treatment because we have a result just from adult literature. So I would like to know if you have some long-term results.
In our department, we usually perform the brushing of the pleural, but I don't have now the long-term follow-up about this mean.
Dimitri, was large the pleural abrasion for many intercostal space?
Usually we start from the apical and we arrive to the 5 intercostal space.
Okay, this is agreed with us and with the work of general thoracic surgeon in my hospital.
Okay, thank you.
No less 5 intercostal space.
Yes, he has to be very extensive.
Yeah.
Have you bleeding after some time after pleural abrasion? We don't need.
No,
we
no,
don't
no.
have.
Never bleeding after pleural abrasion.
The last question from Xara and Professor Bertozzi.
I have a question regarding the abrasing that you do. In which way do you brush the pleura?
We usually use the monopolar or the brushing, mechanical brushing.
With what? With a gauge or with something else?
With a more aggressive gauge.
Okay. Okay. Thank you.
It's more useful also stripping the pleura. It's important to stripping. It's no sufficient to crochet abrasion, no?
Yeah. Also.
Mirko?
Yeah, thank you, Professor Lima. I agree with our president that oxygen therapy 100%. It's effectiveness in some cases of spontaneous pneumothorax. We had 2 cases where we have not the need of surgical procedure as well as of chest drain. So another thing about the brushing, we perform, for example, the brushing with a little gauze used to clean the bladder of the bistoury, and in this manner, if you stay in the rib, not under the rib, you avoid also the bleeding.
I think we have to move to the third paper, if you've got time.
Yes.
Carlo from Pavia, are you ready?
Yes, good morning, everyone.
Morning.
All right. Good morning again, and thank you for your introduction, Dr. Gentilino. Today, I will present to you a paper about thoracoscopic versus thoracotomy lobectomy in children with congenital lung lesions, with systematic review and meta-analysis. This is the work of a Chinese working group published last year on the AMZ Journal of Surgery with the patronage of the Royal Australasian College of Surgery, in which a systematic review and meta-analysis according to PRISMA guidelines was conducted concerning thoracoscopy and thoracotomy interventions for all kinds of congenital lower lung lesions. The authors researched papers in the time period ranging from 2007 to 2022 and included all clinical trials comparing thoracoscopy and thoracotomy with patients under 18 years, and where the original data consisted of some of the following endpoints, which allow to draw comparison between one technique and the other. And in the end, the research yielded a total of 17 studies, which were included in the final meta-analysis. So this is a general picture of the demographics of their patients. As you can see, the numbers are quite impressive, a total of 903 interventions performed in thoracoscopic lobectomy, of course, and 1,192 for the thoracotomy technique. But with a caveat, there is a high heterogeneity regarding healthcare systems, because as you can see, the countries where the studies were conducted are quite disparate, mainly America, but also France, Italy, Canada, China, and so on. And there are also wide variations in sample sizes and patients' demographics. So here are some the results of the meta-analysis. Concerning those that were defined as primary outcomes, we can see that operative times, which were reported in 9 out of 16 studies, showed that thoracoscopy had on average longer operative times than thoracotomy, and the difference was statistically significant, although with a high level of heterogeneity. While even if thoracoscopy allowed for slightly less length of chest tube stays, there were no conclusive differences with thoracotomy technique. And the same was true for post-operative length of study, which showed no relevant differences between groups. The researchers went on to analyze other secondary endpoints, mainly pertaining to complications. For example, the need for transfusion, which was not significantly different between the two techniques. But there was a difference in respiratory complication taken as a whole. So pneumothorax, but also pleural effusions and pneumonia, where, as you can see, thoracoscopy allowed for, in the work, which of course presented these differences, a less rate of incidence, which was statistically significant. And finally, they also analyzed the wound infection, for which there were no statistically significant differences, and overall postoperative complications, that is, wound infection plus other kinds of respiratory complications, plus other kinds of complications which were not included in this macro category. And in this case, again, we can see that in the thoracoscopic group, the rate was lower, with a statistically significant difference and a low rate of heterogeneity. So what are the conclusions that they do draw for this study? That no significant deviation was observed between thoracoscopic lobectomy and thoracotomy in terms of chest tube length of stay, transfusions, and postoperative length of stay in the hospital, which contradicts another recent meta-analysis where thoracoscopy proved superior. There were longer operative times for thoracoscopy, that was definite, and they argue that this may be due to the influence of a learning curve, because when other articles were analyzed with a larger series of thoracoscopic surgery, as the one I reported here, the operative times got lower and lower for thoracoscopy as time went on, and the surgical team had more skills to bring to the table. And there were lower overall complications rate for thoracoscopy lobectomy than for thoracotomy. They also postulated the difference maybe even greater if long-term and musculoskeletal complications in particular are included, but there are no definite studies to support this speculation. No statistically significant difference regarding with infection, and a new data which has not been proven in previous literature is that a lower overall respiratory complications rate for pneumothorax, perfusion, and pneumonia in the case of thoracoscopic lobectomy. But the authors do not speculate for the possible cause of this statistically significant difference they found. Of course, the study has their limits. They acknowledge that all the clinical trials were retrospective cohort studies, so they are especially subject to likelihood of bias. There was, for the majority of evidence, a high heterogeneity level for different healthcare systems and variability in demographics, and the follow-up was comparatively short, in the order of a few months, they said, which makes it difficult to compare other kinds of sequelae in the long run. I thank you for your attention and I'm happy to receive questions.
Thank you, Carlo, very well presented. The paper is open for discussion. Any comments or questions from the audience?
That's interesting paper. You know, open surgery is much easier than endoscopic surgery. And these results clearly show us that even with the more difficult access with endoscopy, we have at least the same results with open technique, and in some aspects even better. Of course, there is a lot of different factors influencing this data, but we know all the people who already started with endoscopic surgery, they know that these patients are doing much better, really much better in terms of hospital stay, in terms of lung chest tube insertion, you know. And I know some centers who are really very experienced. They are doing even lobectomy as a day surgery that looks almost impossible, you know. So, for instance, at my department, if we are very happy with the lung resection and there is no leakage, there was nothing special at the operating time. So we just put the drain for 24 hours because usually there is some liquid connection. And after chest tube removal, we send patient home, you know, so it's really advantage. And of course, this paper is not talking about long-term sequelae, but we know what does it mean for the young patients to open the chest. And we know exactly that the risk for chest deformation is really high after open surgery. So I think this is the way to go, you know, even that this paper show us just only small improvements. But if the technique is more difficult and we have almost the same result, this is the way to go.
Thank you, Professor Patkowski, for your considerations. Actually, regarding long-term complications, that got me particularly interested. So I went to look up for one of the articles that was cited in this paper, which was the only one providing some insights into that. And they also conducted a review of the literature with their comparing with their experience. And they found that there was a definite difference in some of the long-term musculoskeletal sequelae, especially for winged scapula, interesting, and even if less pronounced in the height of the thorax, which was operated on compared to the other, which is the difference was shorter in patients which were operated with thoracoscopy than in those operated with thoracotomy. And they looked also for another paper which instead showed a difference on multiple levels. So not only with scoliosis, you know, while there seemed to be no difference in the rate of movement, which was retained by the scapula and the articulations of the shoulder, and the power, the force which a person can apply. But there were definite cosmetic differences. So that's a shortcoming of the paper, but luckily there are other papers to draw conclusion from.
Thank you very much. Darius, I think that is ready from Genoa. Torre?
Okay.
I think because ask me that are ready or not. Okay. I don't hear you.
Okay, I'm here. Could you hear me?
Yes, and we see your laptop. Okay.
Okay, good morning, everyone. I'm Ida Barretta from Gasolini Institute of Genoa. And as part of Professor Torres' team, I will briefly present the case of the patient who will undergo today a minimally invasive repair of pectus excavatum using the NAS procedure. The patient is a 15-year-old male with pectus excavatum presenting with exertional dyspnea and psychological discomfort. He has no family history of chest wall malformation or pneumothorax. The pre-operative assessment revealed an abnormal axis deviation on ECG and a mild restrictive tendency on spirometry. Imaging show an Haller index of 3.8 with no evidence of Bleb's or Bullow's disease. The correction index was calculated at 20%, further supporting the indication for surgical correction. And this is the three-dimensional reconstruction with the Titanic index calculated at 94%. Here we can see some pre-operative pictures of our patient. And surgical treatment was indicated due to the chest deformity, poor adherence to conservative treatments, and symptoms affecting daily activities. Additionally, the patient reported significant psychological distress with a very low chest self-perception and satisfaction score, further reinforcing the need for surgical intervention. The procedure will be performing using MIRPE with a NAS technique with cryoanalgesia for an optimal pain control. The number of bars is calculated on the basis of Titanic index and intraoperatively correction result. And bridge stabilizers will be used to prevent displacement, bar displacement. Thank you for your attention. We're happy to take any questions before proceeding.
Thank you very much. And is ready from the operative theater of Genoa?
Yeah.
Is connected?
Hello to everybody. I'm Michele Torre. We are now preparing the position of the patient. In 2 minutes, we are scrubbing. If you, I don't know if someone have seen before.
Michele, excuse me. Please to remove the screen of the laptop of presentation because you don't. Okay, now I have your picture. Thank you very much.
Okay. I just wanted to add something about the analgesia. We are now following a protocol with cryoanalgesia and peripheral block with PEX2 block, which means a local anesthesia below the pectoralis minor, between pectoralis minor and serratus. This is was performed by our anesthesiologist just 5 minutes ago on both sides under sonographic check. Now, during the procedure, the first thing will be cryoanalgesia on both sides. We will touch 5 or 6 intercostal nerves from T3 to T7 or 8, and this has been shown as better than epidural catheter in a lot of papers. So we are following this this policy, cryoanalgesia and peripheral block. We prefer intra-operative thoracoscopic cryoanalgesia. We don't have experience of percutaneous cryoanalgesia, but this is, I think, more complicated for us because it requires 2 sedations, and we don't have experience of that. Now we are doing cryoanalgesia with only 1 minute of treatment. Before we used to wait 2 minutes for each level. Now we will perform 1 minute for each level because literature showed that it's enough. The same result, 1 minute or 2 minutes. Okay, we will come back later when we are doing cryoanalgesia, okay?
Okay, thank you very much. Mirko, you are ready for your presentation?
Yes, Professor Lima, I'm ready. I try to share my screen. Can you see?
Yes, we can.
So this is a case report that we had in Pavia, and this case report resumed all said by Dr. Dimitri in the review of the literature, but we can go ahead, and we know that there were only consensus statement from USA and from England about the treatment with the guidelines for the spontaneous primary pneumothorax till the 2023, when the general recommendation for initial treatment is a conservative needle aspiration or tube drainage in other cases when is asymptomatic, or surgery if recurrence prevention is deemed important, is in pilot of airplane for instance. And after the resolution of first episode of elective surgery, if prevention is deemed for important tension pneumothorax as the first episode, and also elective surgery for patient with second ipsilateral or first contralateral pneumothorax. Surgical technique is approved thoracoscopy, can be considered for surgical pleurodesis. And the thoracotomy access and surgical pleurodesis should be considered for the lowest level of recurrent risk required for high-risk occupation. But these were guideline in the past. Now, in the pediatric population, we have only this management and consensus of the APSA. And for the adolescent and young adults, at the first presentation, there is an observation and the evaluation of symptoms. So aspiration of chest tube placement as first intervention is the pneumothorax is symptomatic or at massive pneumothorax. Primary valves may reduce total hospital day and readmission. And this is the grade C of this consensus. When to operate after first management, when there is a higher leak or inability to resolve the problem, prolonged chest tube management, or a range of 6 hours after failed aspiration up to 48-hour chest tube placement with ongoing higher leaks seems to be reasonable time frame for decision making to proceed with surgery. How to intervene? Tapered blebectomy via assisted thoracoscopy, and approach should be performed on bulla and blebs. There is the consideration that can be given to the apical wedge resection if no lesion are identified. And a pleural procedure, in addition to blebectomy, is recommended to decrease recurrence. And this is the case, a 15-year-old boy with a history of recurrent pneumonia during childhood, 1 episode per year. And he had a Marfanoid habitus, but the genetic exams were negative. So in October, there is an access to peripheral hospital for thoracic pain and dyspnea, and the X-ray show this pneumothorax. And it was a drainage was put in place, put in the thorax, and it was subsequently transferred to our hospital. We start an antibiotic prophylaxis and oxygen therapy at 3 liters per minute. So initial difficulty to maintain adequate, there is initial difficulty to maintain adequate saturation. And after some hours, there was a amelioration with from oxygen therapy. After 4 days after the exam of the liquid of the drain, we found IgG and IgM for chlamydia and mycoplasma pneumonia. So antibiotic prophylaxis with therapy, with ciprofloxacin was started. But the problem is the persistence of pneumothorax after 4 days. So we perform a CT scan, and there is this picture. There was this picture, as you can see here. So we think that with our radiology, there is a penetration of the parenchyma, a scare here in this point, and we decide to wait and see, but repositioning the drain at the apex of the thorax, because before is in the mediastinum. So to have the possibility to reduce the pneumothorax. And this was performed under sedation. And after 7 days, the pneumothorax decreased. So was removed the chest tube. And after 1 week, we have a little component of hydropneumothorax that appeared to be shrinking, and we discharge the boy. So as you can see here, a little bit of remnant of pneumothorax here. So after 1 month, after 1 week, we check with the X-ray, and he goes well. But after 1 month, we had this picture. So a recurrent pneumothorax, here you can see, and we repeat a CT scan that confirmed that massive left pneumothorax with right cardiac shift. So the problem is, first of all, the penetration of the chest tube through the parenchyma here, and this is a scare in the parenchyma, and possible blebs, microblebs, not referred by our radiologist. So at this moment, we think to perform intervention, and this is the picture we see. You can see the parenchyma, the pulmonary parenchyma, full of adhesions that we remove. We perform section of this adhesion, and in some cases, blunt dissection. Then, after seeing the CT scan, and after free all the lung, we're looking for possible air leak. But this maneuver was negative. So you can see here, we free here the portion of pulmonary parenchyma where there was the scare of the positioned drainage. Then we see this situation, and without a proof, we perform an little section, remove the apex of the superior lobe, left lobe. So this is the manner that we perform the pleurodesy, mechanical pleurodesy with the sponge, hard sponge, and we perform a large pleurodesis. And this is for safety. We put over the suture line Tacozil that to prevent air leak. This is the positioning of two chest drain, lower and the apex of the problem and of the thorax. Fortunately, postoperative histological report blebs and multiple subpleural blebs bordered by tissue with low intensity inflammatory and fibrotic reaction. So we do a good choice. We have a good choice to remove the apex of the lobe. Postoperative course was eventful. However, the left apical pneumothorax and basal pleural effusion persisted despite repeated attempts at suction from both chest tube. And the tube was then tried to remove after 90 days and 20 days. It's a very long time. But the pneumothorax persisted, and we perform a radiosurgery. So we consult our adults thoracic surgery to try to understand if the problem is a missing higher leak or some other. But they say that the problem can be the recurrence because the mechanical pleurodesy was not effectiveness. So we repeat surgery, we redo surgery, and this is the condition. We have some adhesion here between the upper lobe and inferior lobe. We try to free the two lobes, and then we perform a chemical pleurodesis. In this manner, we have had a good result, and the tube was removed at the 5, the basal, and 6 days at the apical. Then, upon we discharged the patient, and this is the check of the thorax after 1 month with evident good results. So for the discussion, I would like to know if would you prefer apical pulmonectomy for recurrent spontaneous pneumothorax if the presence of blebs is not unequivocally evidenced by radiological studies? Which is the validity of mechanical versus chemical pleurodesy? What is your opinion? Thank you very much.
Thank you. Thank you, Mirko. This open the discussion from the audience of these very peculiar cases.
Mario, I have 2 questions.
Yes.
The first, Mirko, as you found the area where was damaged from an incisional tube? And the second question, have you complication by talc powder? Because generally the chemical result sometimes with the Claude-Bellon disease or irritation of ganglio stellato superiore, and sometimes also irritation of the nerve with the pain in the elbow.
Okay, for the first question, yes, the problem of the scare is only evidenced in the radiological CT and CT scan, but we don't found any leakage from the parenchyma. So, but this is the same question that I do to myself. There is some problem. I have not seen some leaks. And for this reason, the recurrence of pneumothorax, because the scare is evident also in the vets, but freeing the scare, we perform the waterproof. So we continue with a apicectomy. And the second intervention with chemical pleurodesis, we have not had problem, absolutely.
But what do you think about talc powder? You reserve this position with the last chance?
Yes.
Not the first choice?
No.
Okay.
For me, yes, because we talk about also with our thoracic surgeon of adult patients, and he also think that chemical pleurodesis is not the first choice, because for the consequence, and if the patient should be retreated for any other pathology, the treatment in a lung submitted to chemical pleurodesis is very difficult.
Okay, thank you, Mirko.
Thank you.
I have a question for both of you, not only for Mirko, but also for Vito and for the audience. Do you have experience with the use of betadine or with the use of transfusion, intrapleural transfusion?
No.
Giovanni.
Sorry.
No, Mirko, parla tu.
No, I'm not experienced in this procedure, so I can't have an answer.
Giovanna, I use betadine as teaching to me the old thoracic surgeon when I performed open treatment of pleural MPM. Because when we perform the LISI with open thoracics in all MPM, sometimes there is a lesion of the lung and a minimal fissure of the lung. To reduce post-operative pneumothorax, we perform betadine in natural preparation in the capital pleura, in thoracic cavity.
Okay, thank you. If Professor Lima agreed, I think we can give the floor to Professor Thiel. What do you think, Mario?
Yes, it's okay.
Holger, could you hear me? I hope it is there. Holger? No. If it is not there.
Okay. Darius called me probably from the operative theater. Hello, Darius.
So we have an alternative, two alternatives.
Darius, you are ready?
Darius and Genoa too.
No, Darius is not ready.
So I think
okay.
Michele, it seems ready. Michele?
Okay.
Good morning, Michele. Could you hear us? Genova, could you hear us? Are you connected?
We see the operative theater.
Yes.
I hope that her high.
Michele, could you hear us? Nobody's answering.
Okay, Michele, we hear you. Michele?
Not really.
But I have opened the microphone, probably. Okay, I see that is open the microphone, but probably don't work. One moment.
Okay, they are trying to adjust, adapt something. Professor Torre, Michele Torre, could you hear? Coming.
Giovanna, if you want, Giovanna,
Yes.
you hear me? If you want, it's possible to do your presentation about surgery of thoracic life tumors with the CPAM spot. Is good? You are ready?
Hear you very well. Excuse me. Which presentation you want from my side? The the UNIVATS or the surgery in a tumor?
I think this is better, the surgery in tumor. We start. And when Michele is ready, I call you. Okay?
I will do shortly. I try to do shortly. So I try to share my screen. Okay. Okay. Could you see my screen? I think yes.
Yes, excuse me. There is a question from the audience. Juan Pablo Perez Rossini. Good morning. I would like to ask if the patient was symptomatic after the first surgery, or if the decision to perform the second pleurodesis was based only upon X-ray. Please, Mirko, if you want.
Yes, thank you.
Answer, yes. Excuse me, but I don't see this message before.
No problem. Thank you. No, the patients after the first surgery was asymptomatic, but any attempt to close the drainage have a subsequent important pneumothorax. So for this reason, we prefer to do a new pleurodesis. Thank you.
So, thank you, Mirko. I try to go on with my short presentation. This is a very special field. It's a field of surgery of thoracic life-threatening tumors with cardiopulmonary support. Sorry, I try, to go on. So, we know that radical surgery plays an important role in the treatment of malignant tumor, improving survival, event-free survival and overall survival, and reducing the risk of local recurrence. In thoracic tumor, infiltrating vital structures such as pericardium, major vessels, tracheal, bronchus, with a positive imaging defining the risk, a cardiothoracic support or a cardiopulmonary bypass can be extremely useful and safely allowing radical surgical excision in selected cases. In adults, there are many reports on the use of cardiopulmonary bypass for tracheobronchial tumor, for renal carcinoma with cavernous invasion, and also with metastatic hepatic tumor. In children, cardiopulmonary bypass have been primarily proposed for Wilms tumor with thrombosis of the inferior vena cava and atrium, or in complex cases of hepatic tumor and mediastinal mass, but the reports in literature are really very few. Okay, sorry. Our personal experience is a small experience because the cases has to be really selected. I treated 5 cases in a period of about 5 years. The age ranged from 5 months to 9 years. They were mainly female, 4 female and 1 male, and the follow-up was quite long. I have seen some of this patient recently, and I was very glad and very happy to see that they are still alive. There were 1 myofibroblastic tumor of the right lung, 1 myoepithelial carcinoma of left lung, a thoracic metastatic high-risk 4-stage neuroblastoma, and also a left high-risk neuroblastoma arising from the right adrenal gland invading the inferior vena cava and particularly the right atrium. And then we applied this technique also in a case of severe hemorrhagic high-risk neuroblastoma of the adrenal gland who invaded the inferior vena cava. So the origin was not a thoracic origin. First example, this was the case of the myofibroblastic tumor invading the upper and middle lobe of the right lung. We did an ultrasound guided biopsy of 2 sites of the lesion, and the answer was inflammatory myofibroblastic tumor, ALK positive. So following the protocol, here under
Giovanna?
Yes, I can stop.
Excuse me, because he's already
Yes.
Michele Torre from the operative theater.
I will
and
stop. I will stop.
And now don't have problem with the microphone. Michele, you hear me, please?
Yes. And you
Okay.
can hear me?
Yes, we heard you.
Sorry for the problem of the microphone.
Giovanna, okay, thank you very much, Giovanna.
Okay, now we are starting, and according to the Titanic index, which was almost 100%, that means that all the sternum is behind the level of the costal cage. So I think it's not a very severe pectus. Actually, we do usually more severe pectus. This is not the most severe, but it's quite sunken, all the sternum. From here, it's already sunken. So I think it's appropriate for this case to use 3 bars to correct all the lengths of the sternum. So we are designing the points of entry and exit from the chest and the thoracoscopic site. We will perform bilateral thoracoscopy for this case because we need thoracoscopic cryoanalgesia. And we have measured can you give me again? We have measured the bars, which will be 355 millimeters, okay? We will use CHM bars and bridge stabilizers. So the incision will be like this on this side. I don't know if you can see. Okay, this is the incision. And on the other side, around here. Okay.
Mm-hmm.
And we will use a crane to lift the sternum. Okay, let's start. Usually we start from the left side. Puoi dargli i bisturi. So we will perform first cryoanalgesia on the left side, so the anesthesiologist can switch off ventilation in the left lung. So we exclude the left lung. Now he has a double lumen tube, so now he's in only right side lung. The cryoanalgesia is this probe is the design by Metron Cryoflex, and the tip is like a golf club, something, and the freezing is just in the tip of the probe. It's very thin, so we don't use trocar for this probe, and we use minus 70 or 78 degrees Celsius, and the gas is CO2. So the gas is, I'm not saying you all the mechanism of the probe, but the gas is expanding on the tip of the probe, so the temperature is dropping down to minus 70 or 78 degrees Celsius. So this will create a nice ball on each level of the nerves. Okay? Sì, l'ho già bloccato.
Michele,
Okay.
I am Giovanna. I have a question for you. So if I well heard, you prefer to use a Cullen's tube in order to have the opportunity to exclude the lung.
Yes, this is we use the double lumen tube because we perform cryoanalgesia. For a NAS procedure without cryoanalgesia, we don't use double lumen tube because we don't we use
Because it's not
normal
necessary.
tube. Yes, we use only thoracoscopic pressure, but in this case we need to go very posterior in order to get the nerve very posterior. This is believed that the efficacy of a cryoanalgesia is is much.
Thank you very much.
Okay, so if you go very posterior, but in order to go very posterior, you need to exclude the lung. Ok, so aspetta un attimo, fagli vedere prima faccio vedere quando entra, poi cambi la visione. Un secondo, sì. Still. Okay, now we enter usually on the same scar.
Michele, there is your height that your height.
Sorry. On
We don't have, okay.
anterior axillary line, usually on the fifth, we put the probe in the sonda. Okay, now we can switch to the thoracoscopic view. Possiamo mettere i flussi, l'atteggiamento, sì. Ok, vediamo lì? Ok, il pedale ce l'ho? Sì. Ok, so we need the bed, mettete il letto un pochino sollevato il sinistro. The bed is with the left lifted up. The lung is still a little too inflated. Puoi aspirarlo un po'? We press the parenchyma in order to deflate a little more the lung. And the gas is 6 millimeters of pressure. We can count the ribs. This is subclavian artery. So this is the first rib. This is the second rib. This is the third rib. So we will start on the third rib. And as you can see, we can go very posterior. Okay. Direi che va bene. Okay, so we will start with cryoanalgesia on the third rib. We go at the middle of the intercostal space. This is the rib. This is the fourth rib. This is the third, and this is the fourth. We go in the middle of the space, and we start with the cryoanalgesia. This is a 1 minute treatment, okay? Sometimes we are able to see the nerve. Sometimes we don't see the nerve, but we know that if we stay just in the middle of the space, and we have to push a little. I don't know if you can see that. I'm pushing, so the probe is going a little deeper into the intercostal space. So we are confident that the nerve will be treated. So we have to wait. I say to my resident that they have to bring some jokes that are lasting only 1 minute, because, okay, 1 minute. We can defreeze. As you can see, the defreezing is very fast, and we go on the 4th level, and we do the same thing for 5 or 6 levels. I'm not sure if T8 is really necessary, but if we can do T8, we do T8. Sometimes we use a flaring buster stitch, which means a stitch very low to treat the flaring ribs. It's not the case of today. In that case, we go always to T8. If I touch the lung with the tip, is not good. So it's important to avoid the touching the lung. But if it happens, you don't have to pull, because you can tear the lung. So you just have to defroze, and then pull away the probe. Okay. Now we are doing T5. Sometimes I use like Joanne or a grasper for move the lung away.
But
Can you see?
uses
Can you see? Do you have any questions?
was the advantage to have
I can't hear Giovanna. Sorry.
I tried to change the connection.
Faccio andare una Giovanna? No. Unfortunately. I put Joan. Okay. We wait for. Hai respirato il polmone? È ancora sempre un po' gonfio. Ok. Oh, che poi. Always the lingula is in the way, in the middle. But okay, we can go here. So this is T6, okay? You can see T3, T4, T5, and this is T6. Sometimes for the inferior ribs, we need to use the probe like a hook. we are not able to do like a long ice ball, but we use like a hook. You will see. Vediamo un attimo. La 5, forse il numero 3. 3 lunga. Che dici che... Sì, tieni qualcosa. Okay, this is T6. Okay. We will see T7. Monster. Okay, T7, we use like a hook, okay? Like this. This is T7. Allora, mentre faccio la... Ok, comunque abbiamo quasi finito questo livello. Any question?
I suppose, could you hear me,
Yes,
Michele,
yes,
now?
very well, yes.
Okay, okay, better. I have changed the connection. So, do you perform the same on the other side, I suppose?
Yes, yes.
Okay, and in this case, because the pectus was not so extended but not so deep, I suppose you don't perform an elevation of the xiphoid.
Non ho capito nulla. We use the crane, yes. We will use a crane. Why we use a crane? This is we can discuss all the morning about that. I didn't use the crane because it was not existing. So I learned NAS without any crane. But if you have a crane, I think it's good to use it in most cases. Maybe not in 100%, but if you start doing NAS, I think better 100% of cases. And in this case, why I use crane? Because when you have a crane, you have less tension on the introducer and on the bars. When you pass the introducer and you pass the bars and you rotate the bars, especially in that time, when you rotate the bar, if you have a crane, the bar is rotating very well. It doesn't tear any muscle. Otherwise, you can have a tearing of the intercostal muscle and the bar can be less stable. So we have finished the cryoanalgesia on the left side. So now we include again the left lung, okay?
Okay, so waiting that you move on the other side, because I suppose you will change the thoracoscopy going to the right side.
Yes, yes.
I try to finish my short presentation.
Yes, okay. Just to, because there was a question in the chat.
Yes, yes, yes. In the chat, there was no question. They asked if this procedure is recorded, and I said that all the procedures are recorded. I will look again. I will look again. Okay, there is a question coming from Martin Lacker. Hi, Martin. The question is, nice technique. What is the manufacturer of this device?
It's Cryo Metrum Cryoflex. It's a Polish company.
It's a Polish company.
Yes, it's the
only has been written on the chat in order to give you the opportunity to understand better.
Martin, in the chat there is also the correct name of the company.
The answer, yes, it's already there.
Il letto dritto, per favore.
Okay.
Yeah, thank you so much, Michele.
Giovanna,
Yes.
probably already also in the
You are ready?
Yes, in the in the second operative theater of Florence that have a pectus and use a particular instrument for the traction of the sternum.
Okay.
If you agree, I connected with this
Obviously.
operative theater. Okay.
Yes, it is very nice to see the difference.
See, one moment, because I ask if he's ready, because
Hello.
yes, we hear you, but please
Okay.
don't use only one device, please, because I have a problem. Okay. Flavio?
Yeah, Professor Lima.
Now
We are
is
ready
good.
for the NAS procedure. Is a
Yes.
patient with a medium severe pectus excavatum. As you
Yes.
can see, the defect is symmetrical. We do a thoracoscopy for the right side.
Flavio, I
Yeah.
say to the audience that we use a particular instrument for the traction of the sternum.
Yes.
Please, now when you
I show
inside,
you, Professor, I show you the crane. This is the crane.
yes,
Is fixed to in
it's fixed
it's
to the
fixed
table.
with,
Yes.
in a table, and no, now we are you looking in a thoracoscopy now?
Yes, it's not ideal, the vision,
Yeah.
because it's not inside the trocar.
Okay.
Please clean the
We
lens.
used to,
Has to be clean.
yeah, Professor, we used to split the intervention in 3 phases. The first one is suspension. For us, it's very crucial because when we do a right suspension, everything goes in a right way. Mostly for the anesthesiologists because they don't see problem with hemodynamic diffusion or hemodynamic problem with the suspension. We perform suspension very slowly, about 1 centimeter each 1 or 2 minutes. When I show you when the camera is ready, I show you the external suspension. Professor Lima?
Yes, I am. Okay, show you.
This is our system to fix the, no, we are ready? No, we can split. It's better to show directly the, this is the lower part of the sternum.
Yes.
We use a steel wire. We pass the external, okay, we pass the external part of the sternum. We pass through the bone marrow and we exit. That's it. That's our system, and then we fix to the crane. It's very easy to do it. When the patient is younger, we can calculate lo spessore, come si dice? The thickness of the sternum by the CT scan. Just to be okay. And that's it. Now we start the suspension time. Is one, yeah? You prefer to see inside or outside?
Now it's better inside because it's possible to see what is the effect of the traction.
I think inside is more interesting. Okay. You have two cameras, even the camera, no, you have just only, okay. Now we start with the first centimeter. Okay, bye. Antifog. Se volete potete far vedere. Fai vedere quello, Jerry. As you can see, we mark the centimetro. Yeah, we mark.
Yes.
We mark our step. We
yes,
raise the sternum for the first 2 centimeters, and we want to rise around 5 to 6 centimeters. But
please,
we go very slowly.
Please, I won't see the camera of the lens, please.
Okay, I'll show you. Ridammi il centimetro. Lo vuole rivedere? Non l'hanno visto.
Okay, we have a very good vision now.
Okay.
Inside.
We rise up other 1 centimeter. You see? Okay. Don't move the camera when we rise. Otherwise we don't notice the difference. Okay. Perché c'è? A little bit of anti-fog, no? Yeah. Yeah.
Flavio, if you close the zoom of the camera, I think is better the quality of the picture.
Okay.
I agree with Professor Lima. You have to reduce the field.
Sì. Dacci questa. Sì, sì. As you can see now, we already rise how many centimeters? Yeah. Yeah, as you can, 4. We are around 4. And there you can see the difference between before. The correction by the suspension. If we, as you can see inside, our aim is to have a good view a good compassion, heart compassion during the surgery.
Non me lo può far venire qua.
That's why
No, gli devo
we
far
keep.
vedere questo.
Okay. We rise other 2 centimeters, Professor Lima.
Yes, we see. But
Okay.
if you reduce, Flavio, if you reduce the zoom of your camera,
Reduce the zoom. Yeah.
we see better.
Okay, we reduce the zoom. Okay.
No, no.
No. No, questo è zoom. The zoom is ecco, ok. Vai. Ok.
Reduce,
Right.
please.
Reduce, ok. Ok.
Stop. And now
Okay.
clean the lens, please.
Clean the lens. A quanti centimetri siamo? Ok.
Flavio, how many centimeters you want right?
We are at 5.
5. Now
we rise
we
up
have...
the final one, okay? The final one. Right? As you can see now, is the really final. Okay. Sali, sali, sali. Rise, rise, rise. Ecco, bravissimo. Now all the thorax is in suspension.
Yes.
Yeah. And now we dedicate the next 20 minutes to do our incision, our muscle dissection.
Okay. I see that Michele Torre is finished with the cryoanalgesia of the right part. And I asked to Giovanna if it's possible you finish your presentation, and after we connected or with Flavio Facchini in Florence or with Michele Torre in Genoa. It's okay?
Hey, it's okay for me.
Thank you very much.
I tried to do.
Okay, thank you.
Thank you to all of you. I tried to share again my screen and to do quite quickly. So we were speaking about cardiac bypass support during surgery for life-threatening thoracic tumor. I was presenting this first case, 9-year-old female with the inflammatory myofibroblastic tumor, which underwent to chemotherapy with a partial response and then to ALK inhibitor for 11 months. But if you look to this picture, you can see that the tumor was still very big. It's true that in inflammatory myofibroblastic tumor, we try not to be too aggressive, but when the lesion will remain of this size, you can understand that it is necessary to do a surgery, not to leave such a big lesion inside the thorax. So we underwent to a combined surgery. I had the opportunity when I was in Milan and also in Pavia to work very easily with the group of San Donato. That means with the group of Professor Frigiola, who was originally a pediatric surgeon that I had the opportunity to meet also abroad several times. And we did a median sternotomy and interpericardial isolation of pulmonary vessels and a removal of the part of the pericardium which was invaded, a pulmonary bilobectomy, because the lesion affected the superior and median lobe. So there was no complication. We observed, as frequently in cardiac surgery, a right AMI diaphragm elevation, but we didn't cut the phrenic nerve, and this relief recovered with physiotherapy. This patient didn't require further therapy, and she is event-free survivor after almost 71 months. So, second case was a case, very rare case of a patient with a tumor affecting the left lung with an invasion of the left pulmonary artery, pericardium, and left main bronchus. In this patient, I did a bronchoscopic biopsy and also a percutaneous biopsy. The histology was very rare. Myoepithelial carcinoma is a typical carcinoma of the salivary glands. Is a tumor which is not chemosensitive, and the indication is a surgical indication. So we went to cardiac surgery in this patient. The patient has also an intra-arterial defect, so he was treated at the same time. We did a pneumonectomy with extended lymphadenectomy, and I placed immediately an endoprothesis inside the thorax of this patient. I didn't fill the prothesis with air and with liquid, but I left some air in order not to give too much weight that can sometimes be dangerous for the diaphragm. The diagnosis was confirmed. The nodes were metastatic, and so the patient underwent radiotherapy with a 62.2 Gauge of Ray. And there was no recurrence of the thoracic lesion at 75 months. I have seen this patient just last year, but after 5 months, the parents called me because she had a second lesion. This second lesion is an osteolytic lesion. It's not the same tumor, but just to underline that this patient can go during their life to can be affected by a second tumor. So we have to look for this possibility. Excuse me, I am trying to go on. Okay. Third case, this was a very strange case. This was a patient, a son of a doctor, came to the Buzzi with respiratory distress. He had a big mass inside the thorax, and we did a percutaneous biopsy. The tumor was near a high risk neuroblastoma with amplification of the MYC, and the tumor arises from a small tumor from the left adrenal gland. So he underwent chemotherapy, he underwent to bone marrow transplantation, to therapy, rescue therapy with vitamin A and monoclonal anticorps, but he had a remission, but this was the persistence of the tumor inside the thorax. So he underwent to radiotherapy, but at the end he still had a big tumor. And these were the results of the CT scan after radiotherapy. There was still a big tumor invading the intrapericardial vessel and also the pericardium. So we did this surgery under thoracic assistance, and we were able to take away the tumor and also to remove the local nodes. The histological examination demonstrates with a peripheral neuroblastic tumor with extensive and regenerative mature change, fortunately, but also with angio invasion. The tumor was due to the cardio surgical support completely removed, and I had the opportunity to see this patient recently Then we took away the original tumor, the adenoid tumor, with a secondary surgery performed by laparoscopy. And I had the opportunity to see as outpatient clinic this patient after 70 months, and he's still doing well. He has no recurrence. So I think that this very aggressive procedure was at the end very useful, very helpful. But not always we can reach these good results. This was another case of a girl or a female with a big adenoid tumor on the right side, with an invasion of the tumor in the inferior vena cava and inside the atrium, which was symptomatic too. So she underwent directly to cardiosurgical surgery with the removal of the tumor inside the atrium, inside the inferior vena cava. She had a diagnosis of high-risk 4-stage neuroblastoma. She underwent chemotherapy and all the other treatment. We did the removal of the tumor, of the original tumor later, but this patient has recurrence, metastasis, and he died 10 months later. So there was not a good outcome in this patient. Another strange case is not a thoracic tumor. This is an abdominal tumor coming always from the right adrenal gland. This was a very small girl, 4 or 5 months old, and she had the deterioration of his condition due to an intratumor severe hemorrhage, bleeding. So we had the risk to lose the patient in this condition, and I decided to move to the cardiothoracic unit and to perform this surgery under a cardiopulmonary support. So they were able to control the intrapericardial inferior vena cava, because it was not possible to control this vessel by the abdomen or out of the pericardium. We took away the tumor, and this patient is still alive and is the oldest one, because she has a follow-up of 91 months. So in conclusion, cardiothoracic support and cardiopulmonary bypass are rarely used in pediatric surgical oncology. The indications are very strict, are reserved for selected cases and of cases of life-threatening condition where there is no positive response to neoadjuvant therapy. The advantage of cardiopulmonary bypass and support is given by the possibility of ensuring vascular control in case of complication and in case of involvement of large vessels such as pulmonary artery, vena cava, cardiac cavities, and trachea. The rarity of surgical indication, the technical difficulty of this kind of intervention require a multidisciplinary competence in third-level center with pediatric cardiac surgery. Thank you very much for your attention. It's a little different from the other topics, but I think it could be interesting to consider that thoracic surgery is also cardiac thoracic surgery. And cardiac surgery can sometimes help us in achieving good results. Thank you very much. I finish my to share the screen. I don't know if there are some questions on the chat. There is a question regarding the thoracoscopic procedure that you are doing. To both of you, I would like to ask if the optic is 0 degree or 30 degree.
Giovanna, is a question for the two operative theater.
Yes.
And if you want connected, Michele, you are,
yes.
Flavio, you are ready for the...
Yes,
Flavio?
we are ready. Yeah.
Yes, come please.
We are
the
ready
question,
to the second phase of the intervention. This is the internal dissection, medial dissection. We pass through. Okay.
okay, from the audience, there is a question if you use a 0° or 30° lens.
This is a 30°.
30°. And after we asked this, the same to Michele Torre, we connected with Michele.
Yes,
Okay.
30 degrees.
Show
The
you,
same.
okay.
Both surgeons prefer 30 degrees.
Okay, yeah.
And I have another question for you. Do you use 5 millimeters or 10 millimeters optic?
10 millimeters, but we can use 5. We use 10, but it's the same. 5 is very good.
Thank you, Michele. And Florence?
Is I answer is 5 millimeter. You hear me, Giovanna, the answer?
Yes, yes.
Can I say
Okay,
something?
5 millimeters, 30 degrees.
Okay, 5 millimeters, 30 degrees from Florence.
Can I say something?
Yeah.
Yes, obviously.
Okay, so this is the crane I was mentioned to you, and we have passed 2 stitches of 4 steel wire, and we anchored the sternum. We have passed the stitch under thoracoscopic view, and we have lifted up the sternum. Okay, now we are ready for the dissection.
So can we zoom to the crane that Michele showed? I am asking to the regia, because if I well heard, we use 2 stitches than 1.
Yes.
Is it true?
Yes.
That is nice.
Okay, va bene, va bene. Okay, we are starting our dissection.
Okay, now Michele, we are looking your patient. Could you move a little bit the camera in order to show the 2 stitches that you have?
Chi è che lo fa?
Ragazzi, deve venire di qua.
If there are some tricks, because you know surgery. Okay.
Giovanna?
Yes.
In my screen, we have Florence in the left side.
Yes.
And Genoa in the right
Genoa
side.
in the right one.
Okay.
Yes.
If it's possible to have from Genoa only the inside picture is ideal, because we see. Okay, thank you very much.
Questo lo lascio per dopo. Ok. Sì, va bene. Va bene.
Professor Lima?
C'hai l'altro, no?
Yes, Flavio?
Yeah.
It's good. You arrive in the other side, yes?
We arrive on the other side. We have to open the mediasthenic case.
Okay. If it's possible, go inside with the lens. Okay, it's wonderful.
Yeah.
Wonderful picture. Yes. You are in the other side.
We are on the other side. And now we open in our landmark, in our skin, right in the place that we wanna exit. Okay, that's it. For this passage, we use a suction tube.
If it's possible, Flavio, show you the
okay,
this
that's
particularly
a suction tube.
Okay.
This is a technique described from Dr. Ribas from Brazil. He show you the technique we use with a lot of satisfaction. I want to show you, I want to show you our way to bend the bar. We bend the bar, as you can see, in a very asymmetrical way. That means the right part is bended and the left part is straight. We learn this technique from Dr. Pillegard from Denmark. I show you why we use this technique. Lo stabilizzatore.
You use only one stabilizer, yes?
Because we use only one stabilizer, and the stabilizer is very placed in a medial position. That position allows us to avoid any rotation. As you can see in the frontal part of the chest wall, we have a very stable bar.
Yes.
If we put the stabilizer in the lateral way, you see the bar, the stabilizer is just fixed by the skin or the muscle. That's why many other colleagues they fixed by stitches. In that way, Pillegard explained us that we don't use any stitches between the chest wall and bar and the stabilize.
Okay, thank you, Flavio.
Okay.
There is a comment, Professor Thiel. You write in the chat that is a very fine technique. You have a comment, Holger?
No, beautiful channel, very controlled maneuvers. Congrats.
Okay, thank you.
And in Florence, use the drainage tube, but in Genoa, use an umbilical tape. You see, if it's possible to have only in Genoa, only the inside picture, please. Thank you very much.
Okay, we are inside now. It's better to follow this passage from the bar inside to the mediasthenic part.
Yes, slowly arrive the tube.
Very slowly.
Arrive the tube, the suction tube, and now arrive the bar.
Yeah.
Is correct? Okay.
We want to keep this intervention very as safe as possible. Flipper. Una garza.
Michele, you hear me?
Yes. Yes.
Yes. You want to describe this step?
We have passed the upper bar under
Yes.
thoracoscopic vision. We have two scopes, so two trocars, so on both sides. So in the last time we have also checked the tip of the instrument on the left side, and as you can see, there is a very narrow tunnel. Before I used to do a very large tunnel, and I was able to see everything on the left side. But after that, we had a patient who had a bilateral pneumothorax after NAS procedure for spontaneous pneumothorax, and for the buffalo chest caused by our procedure, the pneumothorax was bilateral and the patient died for that. So now I prefer to do a very narrow, not unsafe. I want to see every time the tip of the instrument, but just that, not more than that. So as you can see here, there is a communication between the two hemithoraxes, but not so wide. So in my idea,
you try
maybe,
to avoid a
yes,
large
buffalo chest,
communication between the
buffalo
two
chest.
hemithorax and the two
Yes.
pleural cavity. That could be safe. Could be a good idea.
Giovanna, probably we are
Yes.
ready also for the Red Operative Theater in Florence, when there is a robotic, and we now change. Please, Regia, show the picture inside of the red. Christian, the inside picture of
Mario, I have a question for the Florence group. How many bar they suggested to place in this patient?
Yes. Now I ask to Flavio. You have the picture also of the other, the robotic view, Giovanna?
Yes, I think yes. Is
okay.
No, I don't know because I don't. It doesn't seem robotic. It seems always the same, but I am not sure. Now I am on the screen. I have Michele.
Michele, only Michele?
Only Michele and another screen, but it seems the previous one. If you can connect the voice also. Because the view is related to the passage up to the pericardium.
Okay.
We have the view of a different
Giovanna,
Giovanna, yes, we can see.
We are ready for the robotic treatment of pneumothorax. You see the picture of the inside the robotic?
Yes.
Okay.
Yes, we are able to see also the stapler, which is
okay. If I go in the inside in the operative theater, and please, if you.
Yes, I will share with Vito the session. We will chat together. I would like to ask the Regia to put the Sala Rossa in evidence, if it is possible. Okay, now it's okay.
Thank you. Thank you.
Sala Rossa, could you hear me?
We don't hear anything.
Yes. Could Mario or the surgeon from Sala Rossa?
I use a robotic stapler.
Okay. I would like to ask you if you use the robotic.
45 millimeter.
Okay.
Non sento bene quello che dice.
Very well, go on. So I have a question. How many trocar? How many arms are you using? 3 arms? That means optic and other 2, or more, or 4?
Three trocar, 1 optical, the right hand and the left on 8th intercostal space.
Okay.
And how old is the patient?
17 years old. No, another. Okay. Sì. Okay. Okay. This patient has already operated for recurrent pneumothorax on left side. This is the right side.
Francesca, you hear me?
Yes.
And Professor Thiel is a compliment for the cleaning technique by the chat. Holger.
Yeah, I keep doing what I'm doing best. I appreciate this lessons and these images. Congratulations into the OR. Beautiful image, nice bleb, and delicate handling with a wristed instrument on your right side. Great work. Thanks.
There is another.
Io non sento che mi dice. Okay. Okay, thanks.
Flavio?
Okay.
Flavio?
The last one.
Flavio Facchini and Michele Torre. You hear me, please?
Pass the second bar.
Hello.
Okay.
Hello.
The audience ask how many bar in the chest and also the position in the chest wall in subcutaneous or submuscular spas. Please.
Okay.
For Flavio,
yes, remove the stapler, please.
Yeah, we put, I don't know if you see the camera, the trocar, the camera through the trocar. We put 2 bars, and the position of the bar is submuscular.
Submuscular.
Submuscular. Every part of the bar, external part of the bar, is placed under the muscle.
There is another question for the both surgeon for the pectus. For how long you left the bars?
Yeah, actually, we split to 3 years, and now we leave the bar 2 years.
Michele? Michele Torre?
We use 2 or 3 bars.
We prefer to leave the bar just 2 years for many reasons. The principal reason is the management of the bar. After 3 years, the bar are too much surrounded by adhesion and bone reconstruction, bone tissue around the bar.
Okay, thank you, Flavio. Thank you, Flavio. Michele?
Okay.
Yes, we use all patients at least 2 bars because we want to fix.
If you want to see,
Flavio, one moment. Speak, Michele.
Okay.
Michele.
So always 2 or 3 bars in a few cases. In this case, I made a mistake. I prepared 3 bars, but
io
after 2 bars.
vorrei fargli vedere quando stacchiamo.
So maybe.
Flavio, we have opened the microphone, please.
Okay, sorry.
So we prefer to stop and put only 2 bars. On the basis of Titanic Index, I was convinced that 3 bars were necessary, but for this specific case, maybe because it had not a so severe pectus, 2 bars are enough. And so I prefer not to put the 3rd bar. I had to change the exit side of the 2nd bar because I was on the same interspace of the 1st bar, so I chose a lower one. And now the correction, I don't know if you can see the flatness of the chest, but it's very good. So I think 2 bars are enough. Now there is the bridge. Can you mi dai uno stabilizzatore? Però mi devi aspetta, no, dammi il centimetro. Now we have to choose the right stabilizer. 20. And because I wanted to show you how we fix with the bridge. Okay, we use stabilizer which has 2 grooves, okay, 1 for each bar, and the screws are put between the bars and the stabilizer. We don't fix the bars to the rib cage as we used to do before, but we fix 1 bar with the other bar. So this is a bridge technique, and this reduces to 0 the dislocation of the bar. It's the only technique which is able really to reduce to 0 the dislocation of the bar. With this type of bar, we use titanium bar of CHM company. Is a Polish one, again, from Poland. We like Poland. And I show you the bridge, okay? This has 2 grooves, okay? Can you see? So each bar is going in 1 groove, and we put then screws here, okay? But we cannot use, with this bridge, obviously, we cannot put the crossbar. So when we need the crossbar, we use other kind of bars, which are the same of a park, that which have a different system and allow us to use also the crossbar with the bridge, okay? Okay, dammi lo stabilizzatore. Sometimes it's very easy, sometimes it's less. Okay, 1 and 2.
Poi facciamo.
Can you see?
Dobbiamo far vedere il momento cruciale della
Flavio,
rimozione.
Flavio, you have the microphone open.
Okay, I want to show you a crucial part of the intervention, that is the crane removal. As you can see, the defect is quite just a little bit overcorrect, as you can see from this
Yes.
projection. And now we show you the crane removal. Crane removal, please. Tronchesi, please. Alessandra, please. Yeah. No, prima allenta. Ok. Vai allenta. Abbassa, abbassa. Okay. You see? Now we are without crane. We remove the stitches. And that's it. It's a quite good correction.
Now it's better. Now it's better. It's not even correct.
Yeah, now it's better. Okay. Yeah, yeah. Okay.
Thank you. That you put inside 2 bar.
Sorry?
You put inside 2 bar.
2 bars. There are 2 parallel bars.
Yes, yes, I see.
When we choose the parallel way because the defect is was very symmetrical, and we don't need to cross the bar or to avoid the flare ribs. We don't have any problem of flare ribs in this chest. Okay.
Okay, thank you very much, Flavio. And now we move for the robotic.
Okay, thank you,
robotic
Professor.
operative theater, because Francesca Tocchioni do a pleurodesi. Vito, what you think about, is correct this pleurodesi?
Yeah.
Yes.
Yes.
Non dica a me.
Because
I use crochet on no robot, but it's the same procedure.
In this step, Vito and other friend, in this step, the robot is fantastic.
Oh, yeah.
With the thoracoscopy, sometimes it's very difficult. With the robot, it's very easy to do a pleurodesi that show Dottoressa Tocchioni. Okay, Francesca, what is the rib that you now touch?
Yes. I perform probodesis to complete the surgery to prevent the recurrent pneumothorax. And for the moment, with the monopolar.
Pay attention with the open microphone. There is a question for Michele and Flavio. You listen me, Michele and Flavio? Michele? Michele, you hear me? No. Flavio?
Yes, this question is very interesting. The question
yes.
how magnet.
Flavio and Michele. Don't hear me.
I can hear you.
Okay. The question is, what is your opinion about the magnetic method of correction of pectus excavatum?
I don't have any experience with that.
Non siamo più connessi, vero?
Siete ancora collegati, Francesca?
You have to do retrosternal dissection. So
on the other side,
I would prefer to put a bar, not a magnet. So the result is quicker. But I don't have experience about magnet.
Michele and the colleague of Florence, what do you think about the technique of bar placed just outside under the muscles? I don't know if you can hear me.
Okay, I think you are talking about pectus up, a technique
Exactly, the technique of a pectus up.
Yes, we don't have any up. The only experience we had is that we remove some pectus up material from the chest and split to prosthesis or NAS procedure.
So you saw complication of this technique.
We just see the complication about pectus up, but not a direct experience.
Have you seen several cases or just 1, 2 cases?
We see about 5 cases in the last 3 years.
So it's a good number.
Yeah, but I don't think I think it's a good idea, but I don't think is so easy to put in everything in order to have a good correction. It's a good idea, it's a good philosophy, but I think it's still an idea. It's not so easy to realize and correct the pectus excavatum with pectus up system. Yeah.
I agree with you because there is often a malformation of a complex malformation of ribs and sternum, and I am not sure that it's possible to treat by outside without a real fracture. I have the experience in the past with the Ravitch procedure, but you still have to do a fracture to obtain a correction of the disease.
Yeah. Yeah, I agree. I totally agree.
Flavio?
Yeah?
Don't code property your answer. The question is, have you experience of magnetic?
The magnetic one, never. We don't have any experience in the magnetic system of pectus excavatum correction. Zero experience in this technique. We use, we believe, and we use vacuum bell. We start as we have in a pediatric hospital. We start to use vacuum bell very early. Since 5, 6 year old, the patients start to use vacuum bell. And we try to eradicate the problem in the before the puberty.
Okay, thank you, Flavio. And
okay,
Olga.
You are welcome.
Olga, what is your?
Yeah, the question goes to Sala Ross in Firenze. See you nicely cauterizing the pleura, but you come very close to the sympathetic chain at the costovertebral joints. Don't you think so?
Francesca, you heard the question of Professor Thiel?
Francesca?
Yeah.
the pleurodesy, now we put a drainage.
You have heard the question?
No, non ho sentito.
And repeat. Olga, please repeat your
Francesca,
question.
beautiful imaging. But your pleurodesis comes rather close to the sympathetic chain at the costovertebral joints. Don't you think so? You care about that? You stay away?
Yes, I performed the pleurodesis on the bone to prevent to damage the vessel and nerve.
Yeah, the nerve is right in front of your instrument. You see it running down the vertebral column. And thermal spread is rather close, but I'm sure you care about it, don't you?
Sorry,
sei troppo vicino alla linea linfatica, alla linea, al simpatico. Ti sta chiedendo questo?
Sì. Great job.
Yes.
Okay, there is another question from Lorenzo Nanni. Francesca, please.
Yes.
Okay, Lorenzo Nanni, can you please, is a question for the two surgeons for the pectus. Can you please give details on the kind of complication related to the pectus up technique? Michele and Flavio. Flavio?
Ragazzi, il piano drenaggio andiamocene via.
Michele, you hear me, Michele? Michele Torre.
Ha detto che eri tanto vicino al simpatico.
Ah, ok. Va bene.
Michele Torre.
Can you redo the question, please?
Yes, the question is if you ask detail on the kind of complication related to the pectus up technique.
Yeah, the complication about pectus up is always the same. Is the problem about the skin, the pain, the patient at a lot of pain. Over the month, the patient still has pain. Rejection, skin rejection, and prosthesis exposure. We noticed 3 cases of prosthesis exposure. And we try to treat with vac therapy, skin flap, and now we learn how to remove the sap. The tools are the same tools that orthopedics colleagues use. It's very easy to remove. And another complication is that is not the patient. The pectus excavatum is not corrected. Still there. The deformity is still there. I think we should think about the indication of pectus up. Could be interested in some cases, some mild case with not so much tension in the chest and anterior chest wall, but otherwise in other case with a lot of stiffness of chest wall of chest wall, it's very difficult to correct a pectus excavatum with pectus up. Did I answer? Che succede?
انت مشيت من جراح صح؟ من زمان مشيت. طيب والله تعالش. انت فين دلوقتي؟ تحت يعني انت دلوقتي في ساحة المرأة فين؟ في التوجيه. طيب والله وانا اول مرة شفت من فترة بقى. يا باشا فرصة سعيدة. الله يكرمك. اتفضل اتفضل.
5 minutes, and we are connected with also Wroclaw operative time with operative room with Professor Paskowski and Olga.
Absolutely. Anytime you want me.
First presentation, when Darius is ready, I call you, okay?
Absolutely. And I can stop anytime and then we go back and forth. Whatever is fine for you and the audience.
If you want to start with your presentation.
Sorry. Thoracoscopic lobectomy revisited?
Yes, we start with thoracoscopic lobectomy.
Okay.
When Darius is ready, I call you.
Absolutely. Okay. You see my screen? Is that fine?
Yes, we can see your laptop.
Okay, cool. So, dear Mario, thanks again. This is so fascinating meeting. And every time I see these wonderful surgeons, I keep learning. That's why I'm so enthusiastic and have to write into the chat how beautiful everything is. This meeting is certainly very special. Now, I'm here to entertain you with a brief talk about thoracoscopic lobectomy. I called it Anatomy and Complexity Revisited because I would like to take the audience from the basics to the pinnacle. So the agenda for this talk is you better be wise to select your patient's right. You can either perform well, like on the left side, or end up in horrible situations, like on the right side. You need special knowledge about lung anatomy, and especially for the younger people in the audience, this is worthwhile listening. And then you do need some essential skills, of course, in pulmonary surgery, and I'll cover that within the next 20 minutes. Briefly, patient selection. There are a couple of rules. Newborn surgery, leave it to Mario, Steve, Giovanna, Darius, and the real, sorry for missing some experts on the room, but for the real experts. Newborn surgery is so special, especially when you have a child like the one you see the X-ray from, massive pulmonary sequestration, CPAM on the left side, trachea pushed to the right side, heart pushed to the right side. This is an unstable patient, and you don't want to go for MIS in these cases. Instead, it's emergency surgery at mastery level already, and you better know what you're doing. I don't know whether everybody in the room sees whether this is an upper lobe, lower lobe affection. Then CPIM, we usually do them around the age of 6 to 12 months in Europe. I know that the US do them earlier. There are a couple of reasons for that, and I'll come to that when I do my talk about CLEs. One rule we all learn from the masters is if you have large cysts, you have a good case because you simply decompress them and you have a lot of space. And my final plea is, and I'll come to that, is don't miss the complex cases. And that's about all for selection, except for this one. Ever seen a Skinita syndrome with a partial anonymous venous connection? That's a unilobar lung. You won't ever see a fissure in these skimitas. That is a monstrous, almost half the size of the aorta, a monstrous arterial feeder into that malformation. This malformation is not right next to the bronchus. You probably won't have an upper lobe bronchus. You have a medium bronchus, and this is just a brutal anomaly. And even worse so, the venous drainage is not going into the heart. It's probably going to the IVC. Better, and you see, we have seen these pictures already, and we'll see them during the day. Better take a good look which arterial feeders you will see, and then make sure that you don't see these abnormal drainage like we see here in this case, where nothing is as you see. Don't start these cases per MIS unless you are a real expert. Okay, patient selection. These weird cases are around. You better know them before. Knowledge and skills. Next topic. Let me pitch some questions and answers to the younger ones in the audience. You can chat me or you can just wait. Stupid question. Anatomy revisited. How many bronchopulmonary segments has the right upper lobe? Yes, of course. Simple question 3. But how many arteries has the right upper lobe? How many arteries do you need to resect? 3, because you have 3 segments. I know it's a stupid and simple question, but the point I'm trying to make is prepare for that. It's only usually 2, and we'll come to that. The message is, yes, each car is a Model T. Each lobe is a lobe. But each Model T is different and special, and so are the lobes.
Usually there are too much.
Hey, Darius.
Yes.
Let's go to the upper lobe and let's have Steve Rothenberg with us. He knows that I'm talking about him and he appreciates part of it because he's the master of the upper lobes. So the answer to the upper lobe is what is usually the case in these cases is you have an arterial anterior trunk that serves the A1 and A3, and these serve the segments 1 and 3. And then you have a ascending A2 artery in the very posterior part of the fissure. Okay, don't blame anybody else but you if you miss it and it starts bleeding. What about the bronchi? Usually the bronchi follow the arteries, of course, the pulmonary arteries, but not necessarily. You may have 1, 2, 3 bronchi, or parallel to the arteries, an anterior bronchial trunk for the segments 1 and 3, and then with the ascending A2, a bronchosin for B2. And yes, the veins usually branch as the superior pulmonary vein into the veins, but there are cases around where you have no separation of the superior and inferior pulmonary vein. There are many thrills around that. Let's go. For the right upper lobe, it's probably one of the most difficult lobes. It's called the D lobe, the death zone lobe. Why? Because of the A2 and the B2 artery. So you will see Steve Rothenberg now doing the following steps. There are many videos around in the internet, and I appreciate this one the most. It's an older video, but it shows his perfect technique. So the orientation goes with the azygos vein, and what he does first is he identifies and divides the A1 and A3. This is the older device, the sealing device that he uses, and perfect techniques in terms of ligation, cut in between, seal, and cut in between. For good reason, Steve, quote, hates, quote, these instruments that ligate and cut at the same time. There's a wisdom with that. If you use other branches from other industries, be aware that you basically need ties, clips separate from each other and cut in between. Okay. Then you start to approach the veins. Again, here, V1, V3. Same maneuver, seal, seal, cut half, make sure the seal is tight, cut completely. Why are we teaching this all the time? Because lobectomies, everybody is fond of them, but many centers have stopped to do them because if this bleeds, you have 30 seconds to a minute to recover. Careful. Okay, upper lobectomy means find the fissure. This is an incomplete fissure, makes it harder. Incomplete means that there is parenchyma above the structures, and then you need to find the bronchi. This is the death zone. This is the A2 in the posterior aspect. This is a vertebral column, posterior. In the posterior aspect of the fissure, ligation of the pulmonary artery, pulmonary parenchyma dissection until you have the bronchus that goes with the A2. So this is the B2 bronchus. And then you do clip, clip. Never use the ligature on these bronchi. They're not made for them. Use a 5mm stapler if you have them. And that's it. Again, there are many, many videos around, not too many about the upper lobe in this perfection. So thanks, Steve, and kind regards to Denver. Hope you're already up. But he is still the master. Okay, middle lobe. Technically, probably the most difficult in terms of danger, not as dangerous as the upper lobe. Of course, you need to find the A4 and A5 and divide it. The A4 and A5 are usually in the posterior aspect of the fissure opposite of the A2 we just saw. And then the bronchi lie in the groove between the two segmental arteries as they always do. And then you separate them into the parenchyma. I mentioned already that if you have no separated superior and inferior pulmonary veins, you're stuck. And that's about the myth of the middle lobe. And we come to the lower lobe. I'll do that in two segments. In my second talk for the CLE, I give you a straightforward, simple, quote, simple lower lobectomy. And this one I'll make difficult. Question again to the juniors, where's the A6? What is the A6? Yes. Like in the upper lobe, there's the A6 is the artery to the superior segment in the posterior aspect of the fissure. How many arteries do you need to cut when you do a lower lobe? You have 4 segments. How many arteries? True, 2. Okay, usually you have the basal trunk that supplies 3 segments, and then you have, as I mentioned, the superior segmental A6 for the segment 6. The bronchus usually go with the arteries. So you have the basal trunk for the bronchus, and then the A6 bronchus. And then, of course, this is simple. The inferior pulmonary vein is separate from it. When you go to the left side, be aware that you have the lingular arteries A4 and A5, similar to what you have on the right side with the middle lobe that can arise very, very close from the basal trunk. You'll see that in a minute. Okay, I promise to make this one complicated just to end up with the pinnacle of it. This is obviously a lesion on the left lower lobe. So I would probably take the atlas of Goussot we just saw, get myself prepared. Yes, I have 2 arteries. Yes, I have 2 bronchi. Yes, I have 1 pulmonary vein to dissect. Don't you underestimate this case. It is a pulmonary sequestration, and we do see these more often, but not as complicated as they can be. This is the worst you can have. It has 2 major main feeders adding together almost the lumen of the aorta. And note that the dimension of the aorta is much smaller below. So the first thing that you need to take care of intraoperatively is make sure that you don't crash cardiopulmonary circulation once you close them. At least tighten them for a second and see what happens. But the real challenge is this. It is an AV malformation inside the lung, and you don't know who is draining and supplying and draining and supplying, and you'll see the disaster in a minute. Just make sure, and I'll just try to caution you, this is the pinnacle of thoracoscopic surgery. And I'll just be brief with a couple of insights to show you that these lesions are beautiful, that you need elaborate techniques, but again, be aware. Okay, aorta, feeder, get enough length, already done. Clamping, no problem. Clipping, half cut, no problem either. First step done. By the way, note, this is a 10 millimeter clip. 10 millimeter clip. And that vessel is almost as huge as the 10 millimeter clip, as you can see here. Okay, then you turn your attention to the lobe, to the interlobe, and to the fissure. Bad news, ladies and gentlemen, no fissure available. We do anticipate complex vascular situations, and we would love to have a complete fissure so everything is open and obviously visible. But at the end of the day, these cases can become a real disaster, and this is the message. Be humble, be very humble. So while we opened up the parenchyma, this is a technique that I love. It takes me longer than Steve and Darius and everybody in the room, but it's very safe in my hands. I lasso the vessel, I get enough length, I control the vessel centrally with the lasso, and then I have enough space, beautiful space for clips. And now, according to my atlas, there should be a bronchus underneath, and that's it. And there is. But then note this picture. Where the hell is anything? And then note this picture. This is this brutal venous situation, AV situation shunting in the fissure, and it takes a lot of time and tedious. This is, by the way, part of the lower lobe. And remember that you need to preserve the vessels and the bronchus to the lower lobe and the middle lobe, left side. Okay, can be done. That's all. So with this, I conclude this talk. Hopefully, I took you from the basics to the very pinnacle, what can be done. These CPAMs are beautiful. Definitely the target for MIS in our hands, in pediatric surgical hands, but appreciate and be humble with the variability of pathologies and pulmonary anatomy. You do have to have highest technical standards. There is little room for failure. The typical textbook approach means when you approach it from the front, that you open the fissure, you identify the pulmonary arteries, you have the pulmonary bronchi right underneath it, and then you turn your skills to the pulmonary veins. Have experienced people with you when you do the first cases, and if you do well and if you appreciate all these essentials, then patients' benefits are obvious. In the future, I think we will have more guidance intraoperatively. Maybe ICG will give us guidance when the fissure is closed, and anything else that the younger generation will come up with and the industry. And with that, Mario, I close, and I'm happy to take any questions. And sometimes I'll just continue with my CLE talk, which adds on that. Thanks for the moment. Are you guys with me? Darius?
As usually, brilliant presentation. I like it very much. I learn a lot, especially about anatomy this time, That's really brilliant.
Not you, not you.
No, but you know, if you know anatomy, it's easy to operate, you know. That's the saying, you know, so that's fantastic what you are, very, very deductive, but that's really what you show us, that sometimes these cases are really very challenging, and the vascular anatomy is really, especially in sequestration, that easier, you know, CCAM, but sometimes, especially if there is a hybrid lesion, if there are a lot of feeding vessels and also other vessels, I will show you in the moment what I did before. So it's really very challenging. So be very careful with any chest procedure.
That's the point. We do hear about colleagues who failed or had disasters on these, and then you wonder, ho, ho, ho. But the ho, ho is not appropriate. That is not respectful. These lesions can do anything you don't want to have. And so I think this is the message I would give to this experienced audience. Stay humble every day.
Yeah. So thank you very much for your presentation.
Darius,
yes.
Before you start your presentation, I want to ask to Michele Torre. Michele, you heard?
Yes, I'm here.
Yes, you want to show the results of your procedure and the comments, please?
Yes, I wanted to comment because we changed after the last connection, we changed idea and we put at the end the third bar because internally, potete far vedere la toracoscopia? Internally, we were not sure that we were supporting well the sternum with the 2 bars. We have already prepared a third bar, and we decided to put the third bar below because I think an important point for the result of the surgery is to get all the sternum up to xiphoid. You don't have to leave a little dent on the lower centimeter of the sternum. Otherwise, when the patient is lying, everything looks fine. But when the patient comes to you standing and you think maybe I could have put another bar below, that's happened. So I prefer to put the third bar below, okay? And you can see the results. And another comment that at the end, I always check if there is any conflicts between the bars and the internal thoracic vessels. We had a patient who had a very severe bleeding from an internal thoracic artery after 1 month from the surgery. So in that specific case, the superior bar, in my view, was a little conflicting with with the mammary artery. So I prefer to make a bipolar coagulation of the vessels just near to the bars, to the upper bar.
Thank you very much, Michele. And Olga, there is 3 questions in the chat for you. You see in the chat, there is 3 questions for you.
Ahmed is asking, Ahmed El Haddad, my dear friend, how are you? He spent some time with us and he's just a wonderful guy, nice colleague. Ahmed asked me, do we need CT with vascular reconstruction for all cases preoperatively? My simple answer would be, if in a first world setting it is available easily, yes, because there are surprises. It depends, Ahmed, on your setting. If it's not easily available, be smart. But again, wait for these reconstructions and they are brilliant. Then the next question comes from Yerik, asking which age you provide the lobectomy during cyst malformation. And I already answered, as mentioned, in asymptomatic cases, most of us in Europe would postpone CPAP surgery until the age of 3 to 6 months, hoping that no infection occurs. Symptomatic cases, meaning cardiovascular compromise, meaning infection, need to be specialties and operated sooner. I appreciate, of course, that in North America, these patients are operated earlier. Also, if there are, third question, if there are any respiratory disorders, again, these cases are sometimes so individually to be handled that you need to tailor your treatment to the complexity of the patient. Mario, is that good?
Thank you. Yeah, thank you, Olga. And now the president.
Okay.
Okay.
I'm very sorry. Yeah, sorry, I'm very sorry that we couldn't make a broadcast from our operating theater, but could you imagine that the main equipment went on fire? So it's completely destroyed just at that moment, you know. So I just recorded the whole procedure for you and constructed the video. So instead of 1 hour, you will see in 12 minutes for the whole procedure. So it was a 1-year-old girl with a CCAM, hybrid CCAM, with sequestration. So we started with a thoracoscopic approach with lateral position. It was in the left chest. So this is how it went. Look for this. I will speed up the procedure 5s. So we will see all the details. You can see that the sequestration looks quite good. And at the moment, you can see that it is, unfortunately, it's hybrid. It's a big lesion. So this is what Holger showed us, how big vessels sometimes are feeding this. This is unedited video, so we will see all the things. But 10 minutes just, we have time just to show you how it was. So this is what I started, you know, just at the beginning, I had only 3mm instruments. So I dissected the feeding vessels around. And my intention was to ligate it with sutures. You will see at the moment. So right now I am under it. So we put just a 2-0 suture around it. Of course, with the sliding knot that is the most appropriate for all these lesions. So you can see all the problems that we had. Fine. I am happy that it was an uneventful procedure. But as you can see, that the space in the chest is really very good. So just about the details of the technique, you are not using single lung ventilation, even for the lung resection. I always prefer to do a tracheal intubation and both lungs are ventilated. So you can control the space just with the pressure, insufflation pressure. In this case, it was 6mm. That is a standard pressure for us when we do any thoracic surgery. If the view is bad, you can increase at the beginning, but usually when you go with the procedure, you can even lower it to lower the pressure to 4. And especially for CDH, because some people say that for CDH, the CO2 is very harmful. So for CDH, you have a very small lung, so you can even lower the insufflator to 2 or 1 millimeter of the pressure, just to keep the exchange of the gas in the chest to prevent any 4G. So you can see the problem with making sutures. So there are 2 knots on the side of the aorta, and then we will place another one. You will see in the moment on the sequestration side. So this is completely unedited video, so you can watch all the maneuvers that we are doing. It's a 2-0 absorbable suture. The name of it is very strange for me, so I always name them as no-name suture coming from China. Yeah. So you can see on this side, this is also, and I decided to make another one just with the transfixion. You will see at the moment that I put a needle inside. You can see that the vessel is very long, so it was much easier. Sometimes they are very short. So you can see this is the way that you can deliver a big needle. But remember, when you put the needle through the chest wall, be careful, because from time to time it happens that you injure the vessels, rib vessels. So sometimes it's a real problem, and it's really difficult to coagulate it. So you can see that with the sliding knot, just I will ligate it around. So just a little bit more. You can see, and this right now I cut it with the scissors. So it's already cut it off. You can see how big the vessel is. Yeah, so it's already cut it. So right now we can check that this is a kind of hybrid lesion. So there are big vessels going into the lower lobe, but fortunately right now they collapse because there is no feeding vessel. So this is the pulmonary ligament, but be careful when you cut it, because sometimes there is the accessory vessel going through it. So be careful, always check. So this is what I like. I like in lung surgery, I like dissection with the hook. But in this moment I stopped. I decided to take a bipolar instrument. It's not an advertisement. The instrument we are using, this is from Esculap. It's a Cayman. It's a very useful instrument with the blade inside, so you can coagulate and cut. But remember what Holger told us about, it's usually, I don't have a 3 millimeter vessel sealing. So that's my, unfortunately, I don't have it in my department. I would like to have it, but you know, the instrument with the blade is very dangerous. So be careful, because usually it's better to coagulate and cut later, not at the same moment, you know. So you can see that was also, it looked that it was very easy, but I just stopped for the moment. Look, here, it was not my intention, but unfortunately I coagulate a vessel a little bit. It was not that's in this case, but it was a mistake. Look for it. So at that moment, I decided to put a clip. So I like very much Hemolog because they are very stable. Sometimes if the vessel is very big, you can use a loop around the vessel just to compress it a little bit, especially if this is a vein. So you can use even 5 millimeter clip for a big vessel. So just right now I am waiting for a clip. What you will see at the moment, you will get it. Just I move it a little bit. It's already clipped. Yeah, you can see. No, it was calculated, you know. So right now I can feel with my instrument that there is a small bronchus. So this is why I decided to clip it. You can see just the separation, and that you will see the problem right now with the clip, that I put the clip and they move it to that's it. That happens sometimes, and sometimes you have a problem how to take it out, you know. And it always happens that with the tooth it stopped. So just that's what I'm trying to do, and suddenly it went out. Okay, so once again, just putting the clip around the bronchus. And then on the other side, I cut it with the vessel sealer. So a little bit more dissection. So this is step-by-step procedure. Of course, this one is speed up, so you can see that I'm doing it a little bit faster. But usually what I say, you should move very slowly and you will do a very fast surgery. So be careful, especially when you are doing lung. So you can see that this is just the dissection. I was also feeling something that maybe there is a small bronchus, so this is why I put a clip on it, cut it with the sealer. And you can see this is the dissection that I like, just touching it and checking what's going in. Just checking whether I am in a correct plane. That's very good in this case because we had a very good, transitional zone because there is no blood supply right now, so it's blue in color. Okay, so that's it. So the only what we did, we took the needle out, of course, and then we put some water just to check whether there is any leakage, but it was not. So in this case, I decided not to do any chest drain. The only you can see that we just widened the chest incision that was 5 millimeter and slowly took the specimen out. And what I would like to show you, that's very good idea, just to have, you can see this is the only suction. I usually don't like suction and irrigation. And you can see that right now I will put a special drain to the under the pleura. This is our anesthesiologist spinal needle, and just making some room around it, just put some water and put the drain that we keep for 24, 48 hours just to prevent for any pain. Yeah, so that's the whole procedure. So I'm very sorry that I couldn't show you in live, but I hope that I showed you the most important moments of this procedure. Thank you very much. If you have any questions.
Yes, thank you, Darek. And there is many questions in the chat, Darek. There is a question from Lorenzo Nanni to Michele Torre. I ask Michele, you heard us?
Yes.
Okay, Michele, you see please the chat.
Okay.
Because there is a question from Lorenzo Nanni for you. Who can you manage to keep the passage of the bar small? You see the chat?
Yes, I'm checking.
Is the last answer.
Okay. How can you manage to keep the passage small enough when the patient? Okay. Ideally, yes, I create multiple tunnels, but if I'm in a little difficulty, I prefer to do a large tunnel. So first, safety, okay? I have to see very well the tip of the instrument. If I can do that through a narrow tunnel, okay, I go with a narrow tunnel and a second one, a third one. But it's true that usually when I put 3 bars, the tunnel at the end eventually will become large, and it's difficult to maintain, not to create a buffalo chest when you have 3 bars. That's very, very true.
Thank you very much. Lorenzo, okay, Lorenzo, thanks. Okay, is satisfied of your answer. Okay, from the audience, there is question for the presentation of Professor Thiel and presentation of Professor Paskowski. Darius, you
Yes.
always prefer the Hemolock and don't use the clip, titanic clip?
It depends. It depends. Sometimes I use a double Titanic clip, but usually Hemlock are better. They keep much better than any other clip because you cannot open them. You know, that's very good. What I like about these clips. You know, maybe they are sometimes difficult to put because they can block. You know. But I like them very much, especially for vessels, you know, and also for internal traction, yeah. If you are using.
I have also another question for you. When you cut the big artery and you have this situation, it's not possible to use a stapler for remove the sequestration. And why don't you use the stapler? And I don't know with the video if is correct, but what is your opinion?
I would like to use the stapler, but the only available that I have at my department, it's 8 millimeter, you know. So for this small baby, it's too big, you know, to accommodate it inside the chest. So this is why I don't use it. I would, if I had a 5 millimeter stapler, this was an ideal case, both for the vessel, both for the sequestration, you know. Unfortunately, we don't have it.
Okay, thank you very much, because the 5
Mario, I have the same question for Olga and Darius. Congratulations for your surgery, but why not? What do you think with the possibility to use the stapler, the 5 millimeter stapler, for the bronchus in small babies?
It's perfect, but I don't have it, you know. That's the only problem. No.
Now, if the president and the vice president agree, I ask if Valerio is ready, because have the step-by-step lobectomy, and I think it's very didactic. And
Mario, there is a question from the
excuse me, yes.
which is related to the tube presentation.
Okay. In case of bleeding, what is the best way to manage, and what is the conversion rate? Olga and Darius.
If you have an bleeding, you know, that's a custom. When you cut the vessel, don't cut it completely. Just use your scissors, cut a little bit, just 0.5 millimeter. If you see any small bleeding, you can survive. But if you cut it in one piece, then you have no chance to survive. And usually, when you cut any vessel, you need to keep it with another one instrument, you know, just to have any, you know, control. So that's just, you know, the same rules as you have in open surgery, and especially in chest. If you have any bleeding and you cannot stop it in 1 second, just convert it at once. So always my question when I start the procedure, do we have the equipment for conversion? That's always, you know, so remember about it.
Olga.
Yeah, I wrote the same thing that Darius just said while Dario was saying it to Ahmed. Dear Ahmed, a few advices. First, avoid bleeding by getting enough length on the vessel in the first place. If you saw me doing it, I mentioned that it takes longer, but I loop the vessel first, and then I get enough length to place the clips or whatever I use right. A quick way to maybe cut and maybe tie and maybe this, it will one day get you. So get enough length. Then, as Dario said, cut partially only. As long as the continuity of the vessel is still intact, you can grab it. And the third thing, and you see this in all videos from Darius, from Giovanna, from Mario, from everybody else who is doing it, have your left hand right next to the cut. When it starts bleeding, grab it. This is the only chance you have. If not, open up immediately. Don't try to grab something in the middle of this lake. So Ahmed, avoid it. And kind greetings to Egypt.
And also some people try to put clip, especially if you have a clip loader with 10 clips or something like that. The people try to put clips anywhere. It's becoming even worse because when you put clips and you still have the bleeding, you cannot do anything with a lot of clips inside. So just if you can grasp the bleeding vessel with your instrument, it's the best way. Then everyone is settled down, you know, emotions are going down, suck around and check what you can do. But don't fight. If you cannot stop it in 1 second, just convert at once.
I agree.
Just to mention, we're talking about major vessel bleeding. If you have parenchymal bleeding, and you're sure that you're not near one of these disastrous A2s or A6 arteries, then you can go by with vessel sealers and suction. So have suction ready, get an idea of what you're doing in case of parenchymal bleedings. Parenchymal bleedings you will manage, Ahmed, and everybody else.
But also remember when you start with the suction, increase the flow inside the chest, because in other way, when you suck, everything will disappear because suddenly you will use a pneumothorax and then you have another one problem.
I want to say that I agree completely what you said. And for the young surgeon, please don't hesitate to convert if you have a dub, because it's better to convert because the next procedure is good. But if you have a big complication, because in the thorax is possible, we stop it for 1-2 years with your work. And there is the last one. Hamed asked if there is any role for the tissue glow, and Darius, because Olga answered with the chat.
Yes.
Experience of the use of the glue?
Of the glue, you know, for sometimes if you have some small leakage on the parenchyma, I mean air leakage, you can put some glue, but it's not working. So I'm not very, you know, I from time to time I use a glue for esophageal anastomosis when you have not a very good quality, you have some tension, so I put a glue on it. But it's not a routine way for me.
Okay.
Sorry, Mario. One thing we should talk about is on this occasion is bronchial leaks. I mean, vessel leaks are dramatic and must be taken care of immediately. But bronchi leaks may be the headache of your next months. So maybe Darius, you can talk about how to manage a bronchus well, how to make sure that it is completely and sophisticatedly sealed. What do you know about 5mm stapler, 10mm stapler, 5mm clips, 10mm clips? Maybe it's worthwhile to mention that, again, bronchial leaks, they will be a headache for the next,
If you have, that's always very important thing. When you finish the procedure and you put a drain inside the chest and you can see that there is a leakage of air, go back. Don't leave it. Of course, if it is just a bubble for 1 minute, one bubble for 1 minute, it's okay. But if you can see a constant leakage, go back into the chest because it will not stop. That's my experience, yeah.
I think is correct. I agree completely with that.
Because it's much easier to go, you know, in a fresh operative field that you just finished, you know, you remember what was going, you can check what's going on. Usually there is some small bronchus that is open, that is leaking, and you can clip it, and then you are happy, you know, and you can sleep very well.
Thank you, Darek. Now, Valerio, you are ready for your presentation, and I want to ask before if Professor Gorexi is connected. Professor Gorexi?
No, he's not connected.
Okay, okay. Because Darek, we
Yes.
have now prepared in the older operative theater of Florence, put inside a stent, tracheal stent.
Okay, I will call him.
After, if it's possible, I think is better the presentation.
Okay.
Valerio, please, thank you.
Yes, good morning. Well, good afternoon, actually. It's not easy to give this talk after Professor Thiel and Professor Patkowski. My talk would like to describe in details what we do step by step, precisely from skin to skin. It was born as an inborn talk intended for use during the preoperative briefing with my colleagues and nurses. So I apologize with you for its simplicity and for the lack of scientific strength. Actually, the subtitle could be The Real Truth, that in Italian is La Vera Verità. The effort will be to focus on the description of the journey of our patient from the moment he enters the theater to when he leaves the operating block, and nothing more, without mentioning the diagnosis, surgical indication, wine, thoracoscopy, and so on. So having said this, today's patient is a 6-month-old infant weighing 7 kilograms and otherwise healthy. He will undergo a left lower lobectomy. I chose a lower left both because it is more frequently involved in congenital lung disease and because it is recognized by all, among many quotation marks, as the easiest, but everything I will say is in essence also applicable to the lower right lobectomy. First of all, we took the trouble to list all the devices used in the operating room by dividing them between the thoracoscopic table and the open table. Not with the aim of defining the gold standard, an objective that obviously I would never pursue throughout my talk, but rather not to forget anything in such a complex intervention, and unfortunately, given the decline in births, increasingly rare. In the same way, and for the same reasons, this slide lists the actors involved in the operating room. Let's start with the anesthesiologist, whose role is so important in this intervention that we believe it is essential that there are 2 of them, especially if something goes wrong. The second assistant surgeon, not scrubbed at the operating table, well, I think it is essential to have his vision and 360-degree of what is happening around the patient. Personally, I like to call him a surgical team leader. By the way, the second anesthesiologist could be called medical team leader, of course, and unfortunately or fortunately, he's the boss for the rest of the day. Just a word about the first assistant, who certainly mustn't be a beginner in a procedure like this. Far from it, he or she must be a champion of a 30-degree camera. So choose it among the most experienced you've got. The scrub nurse must be able to shift between thoracoscopy and open surgery without any problem. And last but not least, the psychological team that I will talk about later today. Next slide is the only picture taken outside the theater room, and it refers to the preoperative briefing with anesthesiologists, nurses, and radiologists, of course, with whom we try to reconstruct as much as possible the axial and 3-dimensional anatomy of the lung. Sometimes it's a physical 3D reconstruction that allows us to simulate contralateral intubation or any form of selective bronchial block. We feel anatomy is so crucial that in one of the screens of the operating room, we upload the images of the CT scan to facilitate their reading during the procedure if necessary. So the patients enter the operating room with a parent or in our anesthesiologist's arms, as you can see, and without medical devices. Anesthesia is induced by inhalation. The parent is accompanied outside to our psychological team with the promise to report when the actual intervention will begin. Peripheral venous access and temporary orotracheal intubation are obtained. And despite having seen thoracoscopic lobectomies performed with 2 peripheral venous access, but in that case, the operator was Professor Rottenberg and I was in Denver, I have never opposed our anesthesiologists, who I believe rightly demand a central venous access and an arterial one. We only ask the central line to be homolateral to the lesion for the usual reason related to the possible, left in this case, pneumothorax. Our claim, equally justified and mandatory, is the presence of blood in the room. At this point, the anesthesiologist performs the ultrasound-guided erectospine block. A few more minutes lost without price, however, in the immediate postoperative period in terms of analgesia. The anesthesiologist, again, with a flexible bronchoscope, replaces the endotracheal tube with one of about half a point smaller and not cuffed, and places it into the right bronchus. And now two practical considerations applicable, however, only for lower lobectomies. If for any reason you cannot intubate contralaterally or place a bronchial blocker, such in these small babies, well, do not waste your time. Better to go for a tracheal intubation with low ventilation pressure and play with the CO2 insufflated into the chest to get enough room. And then tubes, catheter, probes, as with any surgical procedure, will complete the preoperative preparation. In the meantime, with the nurse, we prepare the operative.
Un attimo.
Non, non. Bien sûr, donc je vous dis toujours respecter, je vous respecte toujours.
Probably is open the microphone of Wroclaw.
Okay.
I close the microphone.
Thank you, Prof. Thank
you.
You
want, please. Thank you.
So in the meantime, with the nurse, we prepare the operating tables. The thoracoscopic one provides short 3 mm instruments on whose usefulness I do not spend other words, and 3 trocars. The first 3 mm for camera and CO2 is a classic polyuse. The second, more cranial 3 mm tube, but Rotalock type, and the third caudal 5 mm, also Rotalock. On all 3, we put spacers so they do not slip into the chest. And on the 5 mm trocars, we will have to replace the cap, shifting from 5 to 3, depending on the instrument used. The Rotalock, in particular, due to its low intrathoracic profile, do not steal precious space for the jaws of the instruments, and thanks to the costal anchoring system, they are very stable, preventing displacement, an annoying event in any intervention, but potentially dramatic in case of unexpected bleeding. The 3 mm camera is certainly very delicate and sensitive, but not having physical contrast with the operating tools is priceless, and that is why we use it without second thoughts. On the 30 degrees, the schools are divided. I'm now used to it, and I struggle without it, especially in confined spaces such as the neonatal hemithorax, but I'm sure it's feasible even with a 0 degree. The 3 mm sealer has certainly revolutionized the world of pediatric thoracoscopic lobectomies, allowing this intervention to be performed in increasingly smaller babies. That said, and I have no conflicts of interest to declare, the old ligature with Maryland tip, or even better, you had them in stock. The very old ligature with tapered tip have always done a great job and still do it, especially on children over 1 year of age. Moreover, the updating of the vessel sealer market is constant. So what we say today is perhaps already outdated. The 5 mm endo GIA has certainly brought us closer to the surgical style of the thoracic surgeons of the adult, but the approval rating is certainly lower than the sealer, and I will try to tell you shortly why. The 5 mm Hemlock instead remains, in my opinion, irreplaceable for the management of vessels and airways. I do not use metal clips either on the bronchi or on the vessels. On the vessels in particular, there are 2 main risks. Well, rather 3. 1, that the clips can dislocate. 2, that they can cut instead of occlude. And the third reason, conceptually more delicate, is that you might want to apply the clips on vessels whose entire circumference is not completely isolated, or of which an adequate length has not been obtained. On the contrary, the Hemlock forces us to have the vessels completely isolated. Needle holders, needle holders are there, of course, but they are generally and hopefully not used. Last tools, let's say particular, are the 3 and the 5 mm angle laid instruments that sometimes, when the Kelly or the sealer do not allow it, help to surround vessels or bronchi in inaccessible positions with or without the help of the peanut swabs, delicate but very effective in such small patients. Very important is the 3 mm sucker that must be used as little as possible to avoid intrathoracic pressure drops and related boring pulmonary re-expansions, but which will be essential in case of acute bleeding, of course. Speaking of acute bleeding between the thoracoscopic table and that of urgency, I keep available an additional trocar and a 5 mm sucker to be inserted to manage a bleeding vessel. Therefore, the thoracotomic table, essential for any elective or emergency conversion, and certainly not urgent, but it's one last thought at the end of the procedure, the table of the thoracic drainage. And then decisive for the success of the thoracoscopy procedure is the positioning of the patient. So no to the heavy arm support and yes to a pack of swabs to hold the left arm. Thin support so as not to interfere with the instruments, transparent sheets to facilitate the vision of the devices, silk tape to stabilize the patient. Equally fundamental is to place the infant on the edge of the table to allow the operator's hands to lower as necessary, expose the armpit to make room for the cranial trocar, and place the patient in a lateral decubitus to have the best accessibility to the fissure from anterior to posterior. To facilitate nurse anesthesiologists, the table is kept in neonatal mode and the head cloth will be of reduced size. As always, and even more so in this case, we expect that the area behind the surgeons is constantly free. Even the slightest fortuitous movement on surgeons' elbows could result in fatal damage to the patient. The cables must run anterior-inferiorly to the patient in order not to obstruct the work of an anesthesiologist, and they are solidarized with each other with steri-strips to further reduce the space. Very useful is the hanging monitor that lowered down to table level greatly optimizes ergonomics. 2 other ceilings monitors facilitate and not a little the nurse, the anesthesiologist, but above all the assistant, who in this intervention, as in few others, must be comfortable, focused, and participating by making the most of the 30 degrees of the optics. And now, beyond the scientific evidence, allow me 2 extra comments addressed mainly to beginners, comments from the gut on ergonomics. The first, well, always try to adapt the height of the table to your needs, and in any case, with the aim of having an angle of 90 degrees between arms and forearms, and above all, try to constantly adapt yourself to the movements of the table if required. If possible, hold the instruments by inserting your fingers as little as possible into the eyelets. This to avoid transient, sudden, and involuntary muscle contraction, otherwise called cramps in the hands. Relax your shoulders, and every now and then, even if it does not seem necessary, detach yourself from the table. Take a walk. I know that I may seem ridiculous, but after a couple of hours working in a very confined and risky space with fine and hyper-controlled movements, the risk of losing patience is far from zero. And finally, last small detail, the ambient green light will help not to tire the eyes. Consequently, the movements correlated. And now finally, the procedure below is the approach to the pleural cavity. We start with a transverse longitudinal incision of 3 mm, 1 cm anterior-inferiorly to the apex of the scapula. Important not only because the first, but because it's the basis of the thoracotomy in case of conversion. We proceed with the minimal dissection of the subcutaneous layer to keep the endothoracic fascia well adherent to the wall. We stop the ventilation for about 10 seconds to make the lung fall down, especially if the patient hasn't got a bronchial blocker. We introduce the Veress needle and check its endopleural positioning with a few cc of saline. And at this point, the insufflation of CO2 at 4 mm with a flow of 0.5 begins. This is followed by the replacement of the Veress with the 3 mm polyuse trocar and the introduction of the camera. If the interlobar fissure is eccentric with respect to the center of the visual field, it is possible to retract the trocar from the costal plane and using the same skin incision to re-enter through the most appropriate adjacent intercostal space. At this point, we proceed to the introduction of other 2 trocars under endoscopic vision. The triangulation, not a classic diamond-shaped, involves the 2 operative trocars more anterior than the optical one, with the caudal only slightly lower as shown in these pictures. At this point, we take time to convince the anesthesiologists that 4 millimeters at 0.5 is the minimum wage to proceed, and that despite an unavoidable increase of the CO2 in the blood, everything is going to be all right. We start with exploration of the pleural cavity to identify the fissure first, as I have just mentioned, which for convenience of dissertation today will be complete. The possible presence of systemic aortopulmonary vessels unknown, although unlikely, the presence of pathological lesions, and more generally to become familiar with the depth of the operating field. To do this, I use two atraumatic forceps, or the sealer and the forceps, but not the Kelly in this phase that I consider a little too aggressive on the delicate visceral pleura. I make a little digression saying that incomplete fissure can make all the difference in terms of duration, bleeding, and generally speaking, risk for the patient. But again, not today. The first real operational step is the section of the lower triangular ligament that, especially in infants around 6 months, can be done with the sealer without the aid of scissors. Hidden in the pleural reflection, you can see the left lower pulmonary vein, which in my opinion represented enemy number 1. Short, thin walls, retractable within the pericardium and posterior. For these reasons, I take all the time necessary to isolate it with the sealer, and if the length of the main trunks is not satisfactory, I continue with the dissection until the bifurcation. Once isolated, I forget about it temporarily and dedicate myself to the fissure. In this case, very scholastic, everything seems easy. More generally, I start from the most anterior portion and open the visceral pleura, reaching the adventitial plane. With my left hand, I grab the lower lobe, and crossing, I push it down and posteriorly. With the right, I proceed with the dissection, trying to identify the main trunk of the interlobar artery. There are two targets at this point, the lingular artery and the artery for the upper segment of the lower lobe. Once identified, I can proceed to the section of A6 and, depending on the anatomy, the basilar trunk or its components one by one. Our aim will be then to obtain adequate length to be able to seal the arteries in two adjacent points, but separated by a bubble of healthy tissue, and it is precisely there that I will cut with scissors, first for half, and in the absence of bleeding, for its entirety. Never in this context, the 3 mm sealer has become irreplaceable. And then if the basic trunk allows it, it is possible to use the 5 mm endo-GIA that on the relatively thick arterial wall behaves with dignity, unthinkable to use it on individual branches. And remember, envelope clips are always an option on arteries as well. At this point, concluded the section of the arteries, two are the options. Make the bronchi and finally the vein, or devote yourself to the vein first. I believe that if the vein is well prepared and accessible, it is absolutely not improper to tie it up at this time and not think about it anymore. The other way, you risk damaging it during the preparation or the bronchi, and in any case, after having tied them, the entire lobe remains literally hanging only from the vein, and honestly, I found it not very prudent. So I go back to the posterior mediastinum, but I won't get into trouble now with the engineers. I do not even think to handle the vein with a 5 mm endo-GIA, which, as I've already said, does not reach very high approval ratings, at least in my hands. On the enemy number 1, I prefer to apply the hemlock and dissect it distally with the sealer if the length is adequate and if the burn does not interfere with the clips. Now remain the bronchi of the apical and for the basal segments. The alternative is again between the 5 mm endo-GIA or hemlock. Given the results that in this case forced me to apply a couple of stitches on the bronchi, I still prefer clips. And finally, if necessary, the fissure will be completed with the stapler, this time appropriate and effective, I would say, or with a 5 mm sealer if available. The lobe is then externalized, morcellated with open instruments through the breech of the caudal 5 mm trocar and sent for histological examination. A hydropneumatic test is performed to check for any air and or blood leakage. The anesthesiologist would retract the tube in the trachea and check with the surgeon the regular re-expansion of the remaining upper lobe. Always through the same posterior skin axis is introduced the trocar drainage, 12 French, connected with the Heimlich valve to the collection box and fixed to the skin with classic Spartan. The closure of subcuticular layer is followed by the application of biological glue to the skin. And if necessary, the anesthesiologist will repeat the block on the rectus spine and proceed to an early extubation of the patient in the operating room. Subsequently, the patient will be sent with his or her parents to pediatric ICU or surgical ward, depending on clinical conditions. Well, I apologize to those who had already seen this talk that I still try to expand and implement. If there was an update session, I would add the following suggestion that could be sometimes useful. Whenever the dissection of vessels become too difficult, start it with the 3 mm instruments, such as a Kelly forceps, then make your way around the vessel with the 5 mm, even if the patient is 6 months old or less, and then go through the pleura with the 3 mm again. Open the posterior mediastinal pleura from the triangular ligament onto the vein up to the fissure. Prepare and ligate the vein, pushing the lobe anteriorly instead of lifting it superiorly. Be prepared to use a 10 mm hemlock, especially for bigger babies or for large bronchi or for the vein proximal to the bifurcation. Again, in bigger babies, do not forget the 80 mm angio-GIA, not specifically designed for pediatric patients, but very, very reliable compared to the 5 mm available in the market. And for the sake of completeness, keep in mind that the market offers us a vessel sealer specifically made for thoracic procedure. Minor bleeding can be easily controlled by a couple of minutes pressure using a peanut swabs. And probably new drains are better than old ones. What about no drains at all? So I conclude, despite any attempt to describe this kind of surgical procedure, even in a step-by-step fashion, I ultimately think that the key words must be flexibility and adaptability. Thank you very much.
Thank you very much, Valerio. Very nice presentation. And
if I can do a comment, I don't know if it is time, Mario.
Yes, yes, yes.
Okay, first of all, I want to congratulate because it was really very didactic, but also very well presented and also good surgery. I agree with you with the use of 3 mm to coagulate the distally the vessel, because I love hemlock, but sometimes a small patient, I think, I don't know, what do you think, Valerio? Sometimes they seem too big, especially on the tip. What is your idea on this aspect?
Thank you for the comment. Too big the hemlock or too big the sealer, Prof?
No, too big the end of the applicator of the hemlock.
Yes, I fully agree with you. I always struggle with the applicator. Sometimes there is not enough room to open the jaws of the applicator. So yes, I trust hemlock very much, but in small babies, it's a bit of a, well, I cannot say what I would like to say because it's impolite, but it's difficult to use those instruments. Yes.
Thank you.
There is a question from the chat, but Olga answer. What is the manufacture of 3 mm trocars? Valerio?
I use Rotalock trocars from Storz.
Rotalock.
Yes.
Okay. Olga, you have.
You vote the same.
Perfect talk, Valerio. Perfect talk. Every detail, perfect. And yes, I agree with the Rotalocks, especially for small kids, thoracic surgery. They're really, really the best trocars. They don't slip out. They take little space inside. They're just perfect. Agree with you, Valerio. And thanks again. Congratulations to your refined techniques and a very elaborate way of teaching.
Thanks.
How if there is other question? No, thanks. Okay. We don't see question from the audience, and I want to ask to Professor Goretzky if hear me, if it's ready for your presentation, Professor.
I can hear you. Can you hear me?
Yes, yes, perfect.
Good morning. Good morning, everybody. Thank you, professors, both Professor Lima and Professor Patkowski, for the opportunity to present my experience, which is not huge, but the cases are very rare in pediatric surgical world. I would like to talk about the experience with tracheal airway stenting. Let me share my screen. Can you see my presentation?
Yes, we can.
Okay, it's a normal mode or presenter mode?
No, it's normal mode.
Okay.
If it's possible to presented mode, I think is better.
Yes. Okay, so I will start with a short plan of this presentation, which is typical through the particular topics and finalizing with summary and conclusions. We'll be happy to have discussion and all doubts, pros and cons to summarize in gremio. The definition of tracheal stents is obvious. They are tubular devices inserted into trachea to keep it open and to facilitate the breathing. And they are crucial for patients with airway obstructions due to various conditions and origins. These conditions has very wide spectrum. For pediatric surgeon, the most common is dynamic airway stricture, either resulting from tracheobronchomalacia, mostly existence together with the esophageal atresia, or so-called excessive dynamic airway collapse, where mostly the posterior wall of trachea is depressed during forceful breathing. Of course, anatomical airways also it's the issue, but in this setting, primary surgery, either plasty or resection and anastomosis is done, but stents have the place in that situation as the tool for prevention of restricture. Tracheomalacia is characterized by the weakness of the tracheal wall and can be effectively managed with stents, which is obvious. Going back to the history, first there were metallic stents, but today these stents must be forgotten in pediatric practice, particularly neonates, because they produce life-threatening complications, which is tracheobronchial wall erosion, bleeding, severe mucosal tissue granulation, and airway narrowing. And in addition, these metal stents cannot be replaced with the time of growing child, so they are once placed for good and bad. And to be honest, almost 20 years ago plus, we used such a stent, Palma stent metallic, and the child almost died during the removal of the stent. And the literature shows the examples of death on table during the stents. So biodegradable stents with quite fresh experience starting from 218 after several probes in animal lab was introduced to children. So in summary, no metal stents, the biodegradable stents should be the tool of choice in pediatric surgery. We have two biodegradable stents. One is polydioxane, which is the same material as PDS sutures, with the absorption time of 12 to 15 years, but we have also other with much longer absorption time, but these require external placements, so the open surgery mostly. But just to fulfill the topic of biodegradable stents, our choice and the tool of first introduction should be intraluminal, this kind of PDS stents. Please note, because they are not radio opaque, please notice that they have two gold markers to be visible proximally and distally, respectively, on the plain X-ray. A couple of years ago, we published our preliminary experience in the topic. The process of planning a tracheal stent requires careful planning and execution with steps. It is critical to ensure the patient's safety and optimize the custom. The prior to placement through evaluation with CT scan and preoperative bronchoscopy, which allows to determine the size of stent is done. And this ensures the chosen stent is the best choice and the placement technique is appropriate, because this is produced custom for particular child. This is custom made. Here is the prescription, all data of stents, diameter charts, and order, formal physical order for the individual patients. Our material was for children as yet who have 11 stents introduction, with localization in trachea in most of them, and in one patient, 4 patients, who had 3 stents in main bronchus, because it was the only airway in the child who had a single lung because of pulmonectomy. I will talk a little later about the details about this.
Professor Gorecki?
Yes, please.
If you agree, we are ready for the operative theater of Florence.
Definitely,
That
of course.
put inside a stent.
That's typical for this kind. I will be happy to see the live surgery and jump again.
One moment.
Of course.
It's possible to remove now your condivision. Thank you very much.
Okay.
And remove totally. Interrupt the share.
Maybe I can.
No, is okay. Thank you very much.
Okay.
Dr. Baggi, you hear me? Christian, you hear me?
Yeah.
Okay. I don't have your picture from. Okay, we have the picture of the case.
Perfect. Good morning, everybody. Today we will manage the case of a 4-year-old boy who is been in our center for bronchomalacia, and that we decided to manage conservatively with endoscopic placement of PDS, polydiosanone stent. The baby was born with genetic anomalies, duplication of the long arm of the chromosome 7, and with other physical anomaly. He has a prenatal diagnosis of aortic arch interruption and interventricular defect. In second day after birth, he underwent cardiac surgery, where it was performed the reconstruction of the aortic arch and the closure on the interventricular defect. In the post-operative period, the baby cannot be extubated because of a recurrent total atelectasis of the left lung. And so he underwent a bronchoscopy that shows a severe bronchomalacia of the left lung with a double external compression. gave by the descending aorta and left main pulmonary artery. Thus, in the same section, has been performed the posterior aortopexy and the placement of the PDS stent in the left main bronchus with of 6 millimeter in size. After this session, the boy was extubated and in a few days was discharged from the hospital without any other respiratory problem. In this last 2.5 years, we follow the growth of the baby and the growth and the consistency of the bronchial wall. And there was a good period, a clinical good period without respiratory infection, but in the last 4 months, the boy underwent 2 pneumonia on the left side, one of the upper lobe, one of the lower lobe. So we decided to place another PDS stent greater than the first, and with the diameter of 8 millimeter. Now the baby is sleeping, so I start with the procedure. To place a stent in our center, we use the rigid bronchoscope and the double check, endoscopic check and radioscopic check. You can see a lot of stagnation of secretion starting from the left main bronchus. Now we have to clean, and then we have to choose our radiologic markers before to place the stent. This is the main carina, and this is the left main bronchus. You can see that we look severe bronchomalacia and a lot of secretion inside. Now we wash and clean. And we need to check the distal carina.
Rabaggi, don't work the video on the left side. I see the carina, I see the main left bronchus, but now is freeze.
Freeze?
Yes.
Now, still freeze?
No.
Chiedo ai miei tecnici. Dice che è frizzato, ragazzi, non va avanti l'immagine. Still freeze?
Now I see that now it's freezing.
You don't see that I move up and down?
No.
Wait a moment.
Yes.
We gotta arrange the situation.
Mario, there was also a request from Michele. He wrote that he cannot hear, but I can hear. I don't know. I think the problem is main from.
I think it's problem of Michele.
Yes, it's not our. It's not an hour.
Let's see.
Everything change or nothing?
Now you restart. We don't see nothing. See your name, but not the picture of the endoscopy.
You need to share your view.
You need to share me. Inquadriamolo dal telefono. No?
No.
Yeah, we are working. The boy is how I said, 4 years old, but the weight is 10 kilos. So a small boy with the
Mario,
bronchial.
hello.
Yes, Derek.
Can you hear us?
Yes.
Yeah,
one
we just
moment.
started
What-
the procedure. It's
Yes.
also very interesting case.
Yes, yes.
If I don't know whether the picture quality is okay, but we cannot do it better. Just in the moment, right now I am just suturing the trocar to the chest wall, and in the moment I will show you the malformation. It's very interesting because it's also hybrid sequestration. You will see at the moment. Just one more suture and I will be ready to show you. The baby is 8-month-old boy. It was diagnosed prenatally. He is doing fine without any complaints, without any symptoms. So it was discovered on prenatal examination. The baby had, of course, the CT scan that show only the small extralobar sequestration, but you can see that, możemy niżej stóp poprosić jeszcze. You can see that the intraoperative picture is completely different. You can see this is the sequester. Here is the feeding vessel. Here is the feeding vessel, you can see. We are using 5mm instrument. And probably there is something, maybe we can close it just only with the clips. So we'll start with the dissection. You can see that this is at the level of the diaphragm almost. So the trocar position, two 5mm trocars are in the anterior in the middle axillary line. One is just behind the scapula. This is the left trocar. The lesion is in the left pleura. So this is just what I like, just blunt dissection. I'm not fan of diathermy. So I think that this is the ideal case just for placing only clips. So you can see that right now I am just under the vessel. Clips? Hemolog? Tak, możecie zgasić, tak, Piotruś. Siądź tak troszkę, okay. So our insufflation pressure is 6mm. The flow is 1.5 liter. So right now we are waiting for a clip. I will put it into my left hand. I am right-handed. I don't like to work with left hand, but in this case it's much easier because it's
Darek,
it's parallel.
Darek, you heard
Yes.
me? Okay. We have the other operative theater that put inside the stand, and we work because it's possible to see your procedure, and I connected with the other operative theater, okay?
Okay, perfect.
Christian, you hear me? Dr. Badge?
Okay.
Thank
We found in the distal part of the left main bronchus also a stenotic component. So before to place the stent, we prefer to dilate with the balloon the stenotic tract.
Dobrze, następny pan Madziu. I potem nożyczki będą.
Fammi lavare prima. We need to wash to clean the vision. Tagli un po' di adrena. Sì. Vai. Vai giù. Sì. Ok. No, mi devi dare. We need to clean much more. Oh, yeah. Okay, we need to oxygenate the baby before start with the the treatment.
We go one in Wroclaw Operative Theater because Professor Paskowski obligation of the vein. Darek?
Piotruś, włączyłeś? I am back. So we already closed the fitting vessel from aorta. Right now we close the vein that is going into the lower lobe. It's a small one, so even you can close it with the vessel sealer, but we will put a clip. Następny, Pani Maziu. It seems that this is just not hybrid, just extra lobar sequestration completely. So this is the procedure that we like the most. So this is why I like Hemolog, because they are safely placed. Jeszcze raz, Pani Madziu. So baby is in a lateral position, a little bit more to the anterior, so like a little bit oblique. Nożyczki. Okay, and that's what's very important right now. When you cut the vessel, always cut it a little bit, just like this. Once again, and then you check whether there is any bleeding. Usually there is some bleeding because there is some blood between clips. But if it is not going, just... Okay, once again. Okay, and as you can see, this is just a small vessel coming from here. So we'll coagulate it with a hook. We are very happy the hook is working. Okay, that's it. You can see it. So we are finished. That the whole procedure. Right now, we will take it with a grasper through the most interior trocar. No nie, Piotrku chce, Wojtku chce złapać z tymi klipsami, bo one zawsze będą potem kłopotem, jak będą przechodziły przez trocar. Dobra, poprosimy tak, nóż. So right now we remove the trocar. A możesz wyciągnąć kamerę i pokazać z zewnątrz, Wojtku? So you can see, trochę do tyłu się cofnij kamerą się cofnij, bo ja chcę pokazać tak. So you can see that we remove the trocar, we put a small mosquito inside, just widen the incision, just a little bit, you can see, and slowly, yeah, that's it. You can see. So that's the whole procedure. We will come back to the chest because we would like to place our anesthesiologist asked us to place, but I don't know whether it's necessary because we will not, nie będziemy drenować klatki piersiowej, znieczulimy miejsca w kłuć, tam nic nie będzie bolało. Dobrze? Okay, so we will just only put a local anesthesia to the trocar sides and nothing more. We will not drain the chest. So this is the finish of the procedure. Thank you very much. If you have any question, I will be happy to answer.
Okay, thank you very much, Darek. And
Yes.
we return in the other operative theater, Dr. Maggi.
We need to fight with the blood. Yes. Okay. There's bleeding from the left main bronchus where we need to place the stent, so we have to control the bleeding and to oxygenate the baby before to start with the procedure.
Dr. Maggi, I asked to Professor Gorecki to continue with the presentation. When you are ready, please call me, okay? You hear me?
Okay, I'm ready. Can I start?
Yes. One moment, because we see your. Okay, if you want share your laptop. Okay, thank you very much. I am apologize for.
Okay, I can stop any time and jump back. Depends on the situation in OR.
Okay, thank you very much.
Our patients, first three patients, all were related to the complications of the esophageal tracheal fistula with esophageal atresia. Two were referred from outside of our hospital. One was our patients, and they have the severe tracheobronchomalacia with exertional respiratory distress and life-threatening episodes of dynamic collapse during feeding. The method is the custom-made, individualized for the patient stent is made in Czech Republic and is delivered in container with separated packed introducer. Immediately before implantation, we manually press the stent and place it into introducer to the removable sheet. All biostents were implanted during the general anesthesia to a rigid Karl-Storz bronchoscope size 4.0. Expansion of the stent was controlled using the ultra-thin optics. Ultra-thin means 1 millimeter, 1.2 millimeters optic. And after implantation, you use the same longer optic, ultra-thin optic, or small-sized bronchoscope, fibroscope to check if the insertion and expansion of the stent is acceptable. The potential complications, it's stent migration, obstruction, airway irritation, and we have to aware of this risk in post-operative management. Here you can see these two gold markers on the plane chest X-ray in one of our patients. So, speaking about early results, there was no failure at implantation. All patients were extubated in OR with effective tracheal wall support. You can see here the expansion of the stent just after implantation, after 1 week and after 4 weeks. After 15 weeks, 17 weeks, and there was no side effect from stents residual. We mustn't remove any residuals. All patients were going smooth through this period. Depends on the condition, which in some patients was permanent and the patient requires restenting, or two of patients were limited to just to one intervention. The children were at home between reimplantations, gained weight. There was no stent-related morbidity. The child required physiotherapy and inhalations. There was no rest distress in long-term follow-up, no dynamic airway obstruction at feeding, and improvement in exercise tolerance and gaining weight. At the long follow-up, the patient was 2 years and 5 years, respectively. You can still see some signs of dynamic collapse or tracheomalacia, but the airways are wider. And I will comment this phenomenon in a minute. This is another patient with widely open airway, and another one with still some signs of tracheomalacia. This is our fourth patient who was the most severe. There was a premature baby with hydrops fetalis, intraventricular hemorrhage, and CPAM occupating all lung with the mass effect. Here you can see after pulmonectomy the shifting back of mediastinum, but within 6 months the child developed the post-pneumectomy syndrome with completely collapsed left main bronchus, and the arrows point the place with stump of the right main bronchus. The child required stenting of the single left bronchus, and after dissolving of the stent, the symptoms of airway distress come back, and the subsequent 2 stents were implanted with wider size, which corresponded to the increasing diameter of airway. The child stays at home during the episode and gaining weight properly. After 3rd stenting, the parents refused further therapy, and after their request, the baby was placed in the hospice, where the child died 4 months, means after resolving of the stent, of the last stent implantation. So, in summary, our limited experience with the follow-up of 31 months shows that there was still persistent signs of tracheomalacia in bronchoscopy, but there was clinical improvement. There was no extended dynamic airway collapse and stridor, and no fatigue at exercise, with good physical development. I think that it's because of the phenomenon of Hagen-Poiseuille law, which tells us that in the pipe flow, the resistance is inversely proportional to the 4th power of the pipe's radius. It means that even small increase in radius significantly reduces the flow resistance, thus improving the ventilation. The 4th power means that twice big is 16 times lower resistance. So in conclusion, despite this limited experience, we consider this technology a safe, effective, repeatable, and reversible option in the treatment of dynamic airway obstruction in children. This technology constitutes alternative for the more aggressive surgery, which is orthopexy or posterior trachopexy, and allows the baby to pass through the critique period of first several dozen of months until the airway grows. To cut the long story short, stents buy time. I much appreciate the privilege of presenting this presentation, and happy to was with you. Thank you again.
Thank you very much, Professor Gorecki. There is a question from the audience. Okay, thank you. Giovanna, open the microphone.
Oh, okay, okay. My microphone. I am very interested in the use of these stents, but I have a question for both groups. For Professor Gorecki, congratulations for your experience, and also for the group of Florence, who have the biggest experience in Italy. They implanted in the past a lot of stents. So I am a little bit worried about the possibility of displacement of the stent. I have seen a few cases in the past, especially in bronchial stents, where the stent displaced and with severe life-threatening complication. What is your opinion and what is your experience? Your experience I have seen already. Thank you very much and congratulations.
beside the child is extubated, it goes to the intensive care unit to be deeply sedated, just to prevent the excessive cough, which might provoke the displacement of the stent. And there is a risk of reintubation because the risk of technique of reintubation, because the anesthesiologist or the person who will intubate must be aware of the conflict between the end of the airway tube and the stent. But still, bedside emergency bronchoscopy with urgent stent removal is the procedure which might be a life-saving, problem-saving maneuver. We do not have such complications. The child was, after the sedation of 2 days, the child was agitated and there was no significant state displacement.
Thank you, Professor. Michele Torre, you have a comment? Juan?
Yes, we are afraid about stents, and we use stents usually as the last chance. If we have a possibility to avoid the use of stent and we can perform surgery, we prefer the use of surgery because we have seen so many complications of stent. I have a question for Professor Goreski. In the case of pulmonectomy, have you considered to put some expander in the right chest to balance the shift more before putting a stent inside?
Not in this child. There was emergency opening of the chest because of cardiovascular compromise resulting from the kinking of mediastinum. But we did it in an older child. We implanted tissue not from this group, and we implanted tissue expander with the valve, which was in some stages reinflated to fulfill the empty chest and to avoid the complication you just mentioned.
Thank you.
If I can say something, Michele, I totally agree with you. And I had experience with 2 cases of a tissue expander after pneumonectomy for cancer, and they work quite well, and they avoid to have an herniation or an angulation of the bronchus. But I am always worried about the complication of stents, I have to say. I agree with your philosophy.
One moment, because there is a question from the chat, and ask, one moment, are there several sides of the stent? This is the question from the audience.
No, definitely, the stent is custom made from the based on prescription made to the company. So we do chest X-ray, we do a CT scan with measurement, and then confirm it with preoperative bronchoscopy. And you must describe precisely what should be the both diameter and length of the stent. We started from the 5 millimeters and 8 millimeters long. So these are very, very small devices. The first patient was a couple of months old. Yeah, this custom-made stent, individual for the patient.
Thank you very much, Professor. And now our great past president, Juan.
Thank you very much, Mario. Now, just a short comment of Michele's question, because we published some years ago already a number of pneumonectomies in children, and we never left any foreign body or something inside. The only thing we did was just not to use under a water seal for these patients in order not to displace the mediastinum, and we left the empty hemithorax to be filled with fluid in the following days. We never used foreign bodies to fill the empty hemithorax. I never had any problem with that. That was published some years ago already, and I think you don't need to use those things.
Okay, sorry. I think that we are ready for the operative theater for put inside the stent. Dr. Maggi, Christian, you hear me?
Yes.
Okay.
Now, if I
Now
can
we-
see
Now we
something.
see very well. In the right side, the X-ray, we see the bronchoscope, and in the left
Yes.
side, your endoscopic picture. Thank you.
See? If I can say something about the size of the stent to place. Correct that these resorbable stent are customized stent, but before to choose the size, we perform a bronchoscopy, and with a balloon, and we place a balloon in the bronchus that we need, where we need to place a stent, and we cuff the balloon. For example, if I want for this baby, I place the balloon 6 millimeters of size of diameter, and I place and I cuff to 6 millimeters. And if the balloon is stuck inside the bronchus, I choose a stent 2 millimeters greater than the diameter of the balloon, because my teacher told me that one of the way to reduce the risk of the dislodgement is to place a stent 2 millimeters in size, 2 millimeters greater than the theoretical diameter of the bronchus. So in our experience, we have no dislodgement with the PDS stent. We have a few dislodgement with nitinol covered stent and with Dumont silicone stent. Okay, now we have quite controlled the bleeding. We place the suction, and then we place the stent. The stent that I pre-mounted on the introduction set has two markers at the edges to drive our placement and to help us for correct placement in one shot. Whoosh. Okay, eventually if the placement will not be good, we can move the stent to place in a correct position with an optical pin that we usually use to manage this condition. Another suction to have a good vision. You can see on the radioscopy monitor bronchography. This is because the balloon was broken, and we place contrast medium inside the balloon. Okay, give me the stent. So. Radioscopy, please. Continuous bronchoscopy. Okay, continues. You can see the tip of the introducing the stent has been released.
The X-ray.
You know the X-ray?
No, we see
the
on
X-ray?
now is return endoscopic. Perfect.
Wait, we wash and we suck. Dammelo più piccolo, diciamo, guarda. Più piccolo da spirare. E dammi un'ottica lunga. Sì, dammi intanto più piccolo da aspirare, Gianni. Now I will try to go inside the stent with a long telescope to see the position, to check the position. Dammelo piccolo e lungo. Short suction catheter. Small. Okay. Now we need to clean in the best way. Sorry,
No problem.
We need to oxygenate the baby. Dammi che vado giù a lavare a destra. I go to wash on the right side. Okay, right side not bad, right? Okay. Right. Okay, we stay in trachea for 1 minute. Gianluca, suction on the left side. Vai, vada, wash. Sei? Dimmi quando puoi che mi devi dar pressione di là a sinistra. Vai, la pressione estensiva. Devo andare qua a pigliarlo. Ok, we need to move up. Dammi la pinza. Because it's too distal. Okay, with the guarda com'è, guarda com'è. It's dirty.
Pero será mío y medio.
Vai, puliscimi, please clean the telescope. Please, radioscope. Okay, dislodged. We need, how can you see this movement as dislodged too much the stent, and we need to replace. We will replace another one if you have time. Dammi che lo tiro via. Sì.
From the audience, there is a question from Professor Gorecki. Professor, you are hear me? Professor Gorecki?
6 per 20.
Is not open your microphone, Professor. Professor, is not open your microphone. Professor Gorecki, you hear me? And open the microphone. There is a question for you. You don't hear you.
Penso, professore, che abbia tolto l'audio momentaneamente. Adesso ci dovrebbe essere.
Okay, Professor, you
Yes,
hear me?
I'm back. Sorry, I have
Yes, yes, no problem.
answer the other phone.
From the chat, there is a question for you because Wahidi Yahid asked you what happened to the radiopaque makers in the biodegradable stent.
Only Mother Nature knows what is going with this precious part of golds. It's absolutely biological negative, acceptable by the organism. So either indwells somewhere in the organism, or the child cough it with the rest of remnants. These are small pieces of gold. There's no technology required for removal of that.
Okay, I think that our colleague is satisfied of the answer. Giovanna, you no. Okay. And I ask to Dr. Baggi because
I am
okay.
I am preparing a new device for the placement because these are devices that you can replace. So we choose another one, and having this stenotic segment along this trapped stenotic of the bronchus, we place a smaller PDS stent.
I see, Dr. Baggi, that you remove
yes,
is coagulo or what is what you remove from the bronch?
The stent with coaguli.
With coagulus.
Yes, but was the stent that was dislodged too cranially. Now I am preparing the new stent.
If it's possible with the lens, it's possible to see what the movement that you use for preparing the stent. External view with the lens.
External view.
With the lens.
Mm.
It's not easy.
No. I don't think so. With the
it's not good
camera.
because you don't have many
room camera, with the room camera. Room camera, you can see.
Yes, perfect.
This is PDS resorbable stent.
Yes, yes,
and
yes.
We have to put inside the inserting set the catheter for the releasing. This is at the edge of the catheter.
Okay.
And so we will place inside.
Is possible to move the room camera, please?
Vai, andiamo.
Okay. Okay.
Okay. Qua. Sorry, but I need a monitor to see my procedure.
No problem. We see now very well.
Okay.
Now it's good that in screening.
Yes. Please, the suction again. Wash. Okay. We need to put here. Mi dai, please, radioscopy? Hey. Ok, 1, 2, 3. Bon. Okay, let's go. Continuous radioscopy.
It's possible to have the external camera, the room camera.
Room camera?
when you have the picture in the X-ray, please change if it's possible.
Do you see?
Yes.
The two radio pack markers inside the bronchus. Look at the stomach. Okay, now I move up 1 millimeter. That is the stent placed. Only 1 millimeter up and we finished.
Ok, qua ora riparte. Ok.
Okay, I think we are okay. Give me the long telescope, please.
And now we check the position with X-ray or with endoscope.
Both of two.
Both of two.
Okay.
Yeah, yes, worked well. And it's possible to have the picture of the X-ray?
Yes. Now we have to wash one more time. But I think we have finished the procedure.
Okay. Thank you very much. And I want to answer to the colleague of Ireland that asked, because problem open is connected now, is the insert a stent in the bronchus for bronchus stenosis in, I think is a toilet. Okay, Professor Gorecki, you want close and conclusion of your lecture? There is all question from the audience.
The stents is not unique and gold solution for all cases. In selected patients, particularly in terms of philosophy of buying time and waiting when the child grows, and the physical law offers us the significant improvement with small growing of the diameter of trachea, it's justified to use it, in my opinion. All reservation against metal stents I sustained. There should be no way for metal stents in pediatric surgery. It's a lethal weapon. But in selected patients, biodegradable stents should be considered as an option with orthopexy or posterior tracheal wall tracheopexy.
Yes, I think that in the second part of our meeting, probably Michele Torre speak about this for the treatment of tracheomalacia, and also there is experience of Professor Briganti of the stenosis of the heart tree. If the president agree, I think that we stop it and a little break, and we restart 2:30. Is good, Darius, for you? Darius, open the microphone because...
Okay, I was so happy watching all of you that I forgot to...
And if you agree, we start with your lecture.
Okay, perfect.
Darius, 2:30, okay?
Okay, okay. So see you again.
Bye-bye.
Bye.
Thank you very much. See you again.
Thank you, Professor Gorecki.